All right. So good morning to everybody. We have the chance this morning to start our rounds with our guest speaker, who is actually a staff from University of Laval, who is very involved in research, and who, with the help of Dr. Lars Grant, will come here and is about to talk about the place of research and emerge, and with the place of decision rules and a bit of all of that. And I think after the retreat, we a bit talked of the importance of research. So I think it's a good timing of things to start today's rounds. So Dr. Emond, the floor is yours.
Merci Antoine. Hi all. Bonjour à tous. I'm going to do the presentation in English, obviously, and you can send me any question in French or English. As Antoine stated, I'm an emergency physician, CCFP and FRCP trained, both certification. I'm a full professor at University of Laval in emergency medicine, and I'm also a senior clinician-scientist at the FRQS level, which is the Fonds de Recherche Québécois en Santé. I'm also acting as from a team leader, and mostly doing what we call a 50% clinician-scientist career, which means that I'm doing half of my time in Emerge and other half in the research center, trying to build tools and clinical decision rules. And that's mainly the subject I'm going to discuss today, building clinical decision rules and an EM research career. I'm also here to answer some of the questions, as I wouldn't say I'm pretentious, but I'm the oldest researcher in the province for emergency medicine at the FRQS level. So I know a lot of the system. So if any of you have any question at the end, we'll be discussing what you can do as an EM research career. Feel free to ask me any question. If my English is not as good and you want me to do it in French, I can do simultaneously translation. I'll try to do that if some are needed. So for the historic, I was trained at the same time as François de Champlain, because I saw his picture there. I was in the same cohort as him, and the same as also as Gregory Clark. So we were all working together at St. Mary's. So I did my family medicine at St. Mary's and then moved to Laval University after all to complete my CCFP and FRCP program. So no conflict, a special conflict of interest. Obviously got grants from funding agencies. We're going to discuss some of the research here, and also an executive members of Best Evidence Emergency Medicine. We've been hosting a Francophone event each year. So some of you want to come. Now it's going to be our 10th edition next year. We may have also a ski beam in French eventually in Quebec. So if you want to see those, so that's my only conflict of interest I'm going to advertise here. Learning objectives today. Mainly, I want you to understand the methodology behind clinical decision rule building for emergency medicine. Recall some of the important aspect and evidence base of emergency medicine for the appraisal of the clinical decision rules, and then recall some of the important steps for a clinician-scientist career. So here is the plan, a very specific plan that we have for the presentation. We're going to discuss clinical decision rule. I'm going to do some of the steps of the clinical decision rule building with example from studies that we've done either in Quebec or we participate in Canada. So you'll have also fresh, even unpublished results of some of the rules. As we go along, I'm going to give you some EBM pearls also for critical appraisal. Then the second part and the last part, about 15 minutes, will be building a clinician-scientist career and answering some of the questions. And the most important part is the green one, which is interaction with you. Obviously, it's in Zoom, but it's easier sometime when we're in person. So if we're doing in Zoom, I'm going to obviously interact with you, and I want you to ask questions as we go along, any interrogation you have. So feel free to raise your hand. I'm going to ask Antoine just to follow the ends up if it happens, because I may not see them because there's so many people. So first of all, I did introduce myself. I just want to know who I'm discussing with, what I'm presenting with. Are you a majority resident or staff, or can you give me a bit of an idea? Who's our who are the residents? So show your hands. So a bit of activity this morning. Click on the hands or show your hands and there we go. So I have an idea where you start with. I'm gonna just have an idea. Resident, resident, resident. And then who are the staff? So we're making a bit of activity this morning. We're at 8:12, so we need to warm you up before we start. Okay. So a lot I haven't answered, but that's probably because they're still looking for the hand button. That's okay. So let's move first with the clinical decision rule in emergency medicine first. I'm going to do about 35 minutes on this. Obviously, don't be shy to ask any question. The clinical decision rule in emergency medicine has been expanding and exploding over the last 10, 20 years. It did started early 2000 with Ian Steele building one of the first clinical decision rule was with the Ottawa ankle and knee rule. So the classical definition is that we need to have a decision-making tool that is derived from original research, which and not a consensus-based clinical practice guideline. And it usually has 3 or more variables from history, physical examination, and simple tests. This is the classical kind of rule. But since it's expanded, we have many different classification of the rule, I would say, or sub-classification. And so the typical rule will be branching box, which you use for, let's say, the Canadian CT-Ed rule. And also we have score, which have been more popular. So you have rules that are stated as clinical decision rule, which are more based on the score, and you have to add up points, and then you get a score. And those are more called stratification tool for us, because usually it gives you a range of prevalence, incidence, or prognosis for your patient, not a direct action what to do. So it's slightly different. The building, though, is similar. So what I'm going to discuss over the next slides do apply for both of the kind of tools that we can use at the bedside. So clinical decision rules emerge. The Bible was published in 1999 by Ian Steele. I may refer to him as Ian, sorry. I know him very well, so it's slip that I'm referring to as Ian. So Ian did publish in 1999 what we call the methodologic standards for clinical decision rules. And then was only refreshed or up to date in 2014. Same journal, Academic Annals of Emergency Medicine, 2014, by Dr. Green, which were a bit of twist that I'm going to show you here. So I'm going to go along with all the steps that were described in the first original 1999, and also show you some of the new 2014 add-on that have been done by Dr. Green. So who knows? I'm the first question to you, and now I want a bit of interaction here. Who knows the basic step for a clinical decision rule in emergency medicine? Who? Antoine is having big eyes there. Is it because you find something on the computer of your ton beau-père? Just kidding.
No, I'm just thinking of like what would be different from any like research project. I guess it would be a lot in the like when you actually prepare and when you're trying to find those criteria that might actually end up being in your list of
potential predictors. Yeah.
Yes.
Yeah. So that's kind of one step, but there's a couple of steps to prove that your rule is useful for clinical purpose, and that's the issue. That some people just focus on the main step of getting a rule, but there are other important steps that needs to be done. I see something in the chat. I haven't opened the chat. I don't know if it's derivation of the rule. Yeah, that's one of the step. So derivation, obviously. So, without further ado, this is the 6 original steps, which are still quite followed, but a bit twisted as we go along. So, really, to have a good rule that is robust clinically and can go further down the road and change your practice, like these Canadian CT-Ed rule. For those who are resident right now, you haven't seen I would say, the magical operation of the clinical decision rule of the CTED rule. Some of us myself have seen this come to practice and changing our practice. So before we go on and have a rule that can change your practice, you need to have basic steps. And this is kind of a 6th stage. So we're going to go along for the presentation of the 6th stage here, and we'll go in details of all the stage. As in the update of 2014, they did focus only on the derivation and validation part. But they had more, I would say, juice on, they had more meat on the bone, putting more description on some of the important aspects as, setting in population, outcomes, predictor variables, and creation of the rules, and then validation and reporting the validation. They didn't really go into the implementation part and also the cost effective. If you go back to the original one, you had the same similar kind of steps. So is there a need for a rule? We're going to go over that. What the rule derive according to methodology standards? Has the rule been prospectively validated and refined? Has the rule been successfully implemented into clinical practice? Would use of the rule be cost effective? So that's kind of one of the last one. And how will the rule be disseminated and implemented? Obviously, those were kind of the shopping list that you had to do for getting a rule up. Usually a rule is ready for clinical application when it's been prospectively validated in a cohort of patients that's similar to yours. So that's the first EBM take-home point. That now the rule, if you see my pointer here, is only when you get to number 3 that the rule can be applied technically in your setting if you have the same population or the same type of patient. So what Antoine, you were saying, finding the predictor variables is just the beginning of the rule. Even if you have a rule that's derived, technically it cannot be applied to your population right now. Any questions before I move on?
No, I don't see nothing in the chat.
Okay, great. So as we're going to go on the steps, we're going to go back to the future, back and forth in time. I'm going to give you some example as we go along in different aspect of the stages for the rule. And obviously we're going to go from 2000 to 2022. So don't worry. Hope you got some gravel for the motion sickness here, because we're going to go back in time a couple of times. So the first step is there a need for a rule? You may have the greatest idea in the world to do a rule, but first you need to prove that it is worth it to do. Is there an issue with prevalence of the condition that's very prevalent, first of all? Because if you have a very infrequent event, then it's difficult to build a rule on. What's the current use of practice? Is there a variation of practice? Is there any different attitudes of the physician when they see a patient? And are the physician good right now to find the patient? So, for example, there was a rule in the past, I'm just going to give you an idea, a rule that we're looking at possible buccal fracture, basically, for children. And they came up with, 3 candidate variables where pain, swelling, and something else, but basically was a clinical exam, which was very obvious for us. So it wasn't bringing any plus value. So first of all, you need to find if the doctors are good or not, or if there's any issue. So if the patient security or safety can be affected by the fact that they're having a different in their clinical practice. So I'm going to give you an example here of how you can do that. It may not always be a lot of studies. It's sometimes small studies. Actually, it's a lot of student studies. Many of the rules I built were from initial student projects that were done asking a question. So that's where the resident and there's a clerk. Is there a clerk on on your conference also? Sorry, I didn't ask initially. I said resident staff, but
it's mostly residents and staff.
Okay.
I did send it to like the clerk with the whole
there we have one at least.
emerge. Oh, at
Great.
Miguel. So yes, maybe it got shared.
So this is the kind of work you can do. So let's so we're going to be to be able to navigate the presentation, on the left corner, you're going to see now this is the icon for headache. So we're going to discuss about the acute SAH topic that we built rule on. And then I'm going to show you the other ones. We're going to discuss ribs, minor complex TBI, and also shoulder dislocation as we go along. So to give you an idea how to build a rule, so we're going to discuss the first, which is the Ottawa SAH rule, which I've been building with Dr. Perry for many years now. First, Jeff, what was one of his first project that he proposed was in 2002, was the utilization of test for acute headache and alert patient. And basically, here's kind of the bottom line we got, just very quickly. So it's not quite prevalent. It's 1.1%. Patient didn't always have a CT and a lumbar puncture. I'm just going to go back in time. In 2000, we didn't have the CT as available as we have right now. So we used to do either CT or lumbar puncture for those patients. And sometimes we would start with lumbar puncture without a CT. So there was a kind of clinical question of what needs to be done and what is the trajectory of the patient. And he came up with the results that there is a difference in patient when they're seeing the patient, when they're seeing a staff at their hospital. And some staff will do lumbar puncture on all patients. Some will just do CT. So there was a lot of variance in the process. So that was kind of first setting. And similar in the same cohort of patient, he did ask the physician, and that's where the accident, the judgment of the emergency physician are interesting, is that he was asking, what is your pretest probability of SAH in this patient? And you can see in the middle, SAH are in white, and the other headaches are in black. And you can see that some were missed by the emergency physician clinical gestalt. And that's where you can say, okay, now I need to build a rule, and because I need to help the emergency physician. And obviously the emergency physician felt uncomfortable doing LP first without having a CT at that time. So the CT use was increasing, and we needed to guide the CT use at that time. So keep that in mind. I'm going to switch another project where we can show that there is a difference. This is our project of ours that's been published. So it was published on rib fracture and thoracic injuries, minor thoracic injuries. So the ones that are discharged from the hospital. So here's a question. When you're discharging a rib fracture patient, what is usually your complication that you're looking at or expecting? Now you can use your mic, you can use the chat. What is your recommendation or?
Well, the complications of just simple rib fractures, well, from trauma, I guess would be, as you say, yes, there's hemothorax, there's also pneumothorax. And in some patients, yes, pneumonia, if they stop fully breathing in. That's pretty much what I'm thinking of. Yeah, atelectasis. Yes, there's also chronic pain, encephy.
So yeah, those are all good questions. So in 2000, there was a couple of articles coming from Europe saying that delayed hemothorax was often missed and happened more often than we thought. So what we did was looking at a historical cohort here of patients, so about 200 patients, and we just looked at the one that actually came back and what was the practice. So we did show that we admit less patients than in Europe in our North American setting. And also that 18% of the patient had unplanned ED visit, a return visit, sorry, to DDD. And half of them had a delayed hemothorax because they had an X-ray that were done when they came back with pain or either short of breath or dyspnea. So 8.3% is quite an important aspect of an adverse event, put that way, or a complication in patient that was very barely reported. And so the question was, we didn't have any rule to decide whether or not you need to be followed or you're at high risk of having a delayed hemothorax. Like you said, most of the time we say, oh, you come back if you have any shortness of breath, fever, if you have more pain, just come back to the emergency department. was no setting. So just go back here in time. There were not in 2022, but we're early 2008. So that's where the idea sprout that we should maybe do a rule for following minor thoracic injury that we're discharging from the emergency department. So similarly, what we did, sorry, it's in French, but it was published in French. So we published a cohort, and we showed that there was about 12% of delayed hemothorax when we followed them. Pneumothorax was very unlikely to happen, was less than 1%. And I'll just give you the pneumonia side in a minute. Most of the delayed hemothorax occurred in the first week. And oops, sorry, there's a couple of typos there, but the presence of at least one fracture between the 3rd and the 9th rib were quite important factors for complication, which was unpublished previously. So this sprout the idea of doing a rule that I'm going to present later on. So another idea of how to start a rule, is there a need? Minor complex TBI. So 65 years old coming in with a BIBA following a e-scooter fall without an helmet. He takes only a blood pressure pill. After evaluation, he has a GCS of 14. More than 2 hours after the injury, you decide to scan him and you find a small subdural of 2-3 millimeter there. So what do you do with this patient? Usually, there's a couple of questions in mind that came out that will probably came in your discussion. Is that with your staff? Is that who will observe and discharge this patient? Is it you, the neurosurgeon, who will be requesting a neurosurgical consultation? Who will be transferring this patient to a neurosurgical facility? So if you want to build a rule, you need to back yourself. So what we know from neurosurgical intervention, and that's coming from a literature review that you can do. So a systematic review was already published. So we didn't publish one, but we found one that showed that basically with minor complex TBI, with a GCS of 13 to 15, there's only 3.5% of neurosurgical intervention, which is, if you're looking transfer wise, it's going to be 30 to be transferred to our neurosurgical center for one intervention. So not very efficient. And if you just look at the GCS 15, then it's very, very low. So it's like 500 transfer for one possible intervention. So there is here a big issue of clinical either variance or use. So as a first step, we did publish, this was published in Brain Injury, and you can see here some of the names at the paper there. You can see some of your staff there. So Gregory Clark was part of the study, and it was like 500 patient. I'm going to round up the number of the patient in the studies because it's always difficult when you have like 20 studies to remember the exact number, but it's just big figures. So 500 patient, 40 underwent scalpel, and so about 8.3% had a neurosurgical intervention. And here are the predictors that we found in this retrospective cohort. Basically, was subdural greater than 4, midline shift, any midline shift, subaortic hemorrhage actually were protecting factor, put it that way. As you can see, the OR, the odds ratio, are 0.3. So interesting, most of the subarachnoid hemorrhage are transferred to a neurosurgical center in our system. So there is a lot of variance here that we need to address with a good rule. And we'll go a bit further down the road. You probably see the updated brain injury guidelines if you're practicing the CUSUM or Montreal General. Those were the ones that are guiding, that were published in 2017. You have to remember those are consensus-based rule, a consensus-based rule. So they haven't been derived as a clinical decision rule, but after they were built by consensus, they were kind of applied to a data set and showing that they were not too bad. So we did similar study has been published just recently this year, looking at the validation, external validation of the updated brain guidelines. And we came up with a similar result that they had basically. So the neurosurgical intervention, there was none in the big one, with 40 patients there. And so you can probably save about 10% of your cohort that don't see a neurosurgeon that can be dealt with emergency physician. But we were left in the middle, and that's what the square is showing. All neurosurgical consultation repeat EDCT for the big 2 and big 3. There was a lot of resources involved in there for very few patients needing neurosurgical intervention or anything else. So if you need to be followed on the floor and admitted, does it need to be in a neurosurgical center all the time? That's a big question because that's a lot of resources. So we need probably to build a better rule, and I'm going to show you something later on. Any question on that step? Is there a need? So I'm showing you different ways of building the clinical decision rule. If not, I'm going to move to step 2.
Go ahead.
Just going to close something here in the Zoom. There we go. So now that you've proved that you need a rule and that you kind of built your background, so how was the rule derived? And here are some of the original basic points of Ian Steele at the top, and at the bottom, the updated one. So they're quite similar. They're important things that you need to do for a derived rule. First of all, definition of the outcome. Very important that it can be reproducible in different settings. So as more granularity that you can put in your definition, it's great. Similar for predictor variables. Always remember that somebody who wants to replicate your study needs to be able to do it without, sending you an email. So able to define your predictors. Are they reliable? Basically, can they be applied similar in the same way from one student to a staff and understand? Also, what are the subjects? And this is another EBM point, and even a clinical take-home message, is that know what is the population of the rule. And that was emphasis in 2014, was the rule derived in a setting of patient population that you can apply with, that you can apply eventually. And know the specifics of that population, because I see a lot of people applying the rule to the wrong population that has been derived for, and then you can be in big trouble if you're doing so. So make sure you know exactly to who or which patient you need to apply the rule. And then there's a couple of things that needs, obviously, are more methodological, sample size, mathematical techniques, sensibility of the decision rule you want to have, and the accuracy. So is it able to separate the true the sick patient from the other ones? Similar to 2014, they just re-emphasized the outcome. It needs to be clinically important and able to be reproduced. And the predictor variables also needs to be assessed initially. So there's a lot of work that needs to be done, like Antoine, you were saying, find your predictors for building that rule. Make sure your predictors are good, because when you start recruiting patient and you need to recruit about 1,000 patients for your rule and to build it, it's always a mess when at the end you're saying, oh, I should have recorded that type of predictors initially, and then you have no use of your cohort. So a lot of brain juice there need to be put in front before we start building a rule. So here's some example of the building of the rule and step that we can do and have been done in the past. So coming back to the headache part, SAH and JAMA 2013 was the first kind of clinical decision rule for SAH. And as you can see here, we're quite transparent because we did propose in that paper in JAMA there were 3 potential candidate rules, and that's something you can do. You may end up having not just one rule when you're deriving, but 3 rules that do similar stuff, that do the similar prediction and sensitivity and specificity. So then that's why you can't apply a derived rule right off the bat in your clinical setting, because similar to a project I'm going to show you later on, you may have more than one rule initially, and that's when you need to validate the rule. So you need to prepare your predictors as you need to refine your predictors as much as you can and define them as precise as you can. As for example, here in the SAH, there was a lot of issue about the neck stiffness evaluation because it happens to be in different rules. So how this was evaluated by the emergency physician, and also when potential candidate had the arrival by ambulance, which was really puzzling for us because this is kind of a culture thing, put it that way. So some are maybe more inclined in calling the ambulance in some setting and less in others. So this is very important when you have a model with this, is that you need to validate, because you may not want to keep the arrival by ambulance And that's such as a predictor of head CT for this patient, So if we go back to ribs, here's a rule that's been published in CMAG Open in 2018, if I recall. And this from our original work here. It was a multi-center work. As you can see, some of the names here from Montreal. Quebec was one of the first multi-center cohort studies that we put forward in province-wide. So we had about 1,200 patients with minor thoracic injuries that were discharged from emergency department, followed up to 90 days. It was FRSQ funded. And we came up with a rule for the delayed hemothorax after a minor thoracic injury. As you can see here, it's more like a stratification tool than the box rule that we decided, a branching box rule that I've discussed. So you see the factor on your left there. So it was a derivation validation study. So that's a technique that could be done to do 2 steps in one. So you can, when you have a big cohort, you can split the cohort and do the derivation in one part and then the validation in the other part. It's well accepted, but still we'll probably need to have an external validation or another validation phase before it's really robust for clinic. But when you do those 2 kind of steps as a technique, it can still be useful for clinical purpose right at the bat. So just very quickly, we came up with age, more than 70 years old was 2 points. High or mid rib fractures, so from 3 to 9 were 2 points. Age 45, 70, 1 point, and at least 3 rib fracture was 1 point. And then on the right, you can use the cutoff you want. Because it's a stratification tool, you can use the cutoff according to your own setting. So if you have a lot of resources to follow those patients, then you may want to follow the moderate and high and just leave the low. If you only have less resources, you may just want to follow the high risk one. Most of them had the delayed hemothorax within a first week. So I will give you a proportion of about 40% roughly, or 30 to 40% of patients that have a delayed hemothorax in the first week. So that's something to be useful for your clinical purpose. And this can be used in a Canadian setting. Obviously, it's been derived in a multi-center and validated multi-center cohort. When you do big cohort studies, like we did that, there's a lot of spin-off. And don't worry, I'm not a Disney spin-off kind of guy, but that's part of doing big cohorts, and you need to tackle other issues. And you did express some issue initially when I asked you, pneumonia, pain, functional impact. So we all look at that, and those are all the publications that we did for our group in different settings. So you'll see some of the name from Montreal because it was a multi-center project. So right where I am, it's the pneumonia. So basically, as you can see the title, patients with rib fractures do not develop delayed pneumonia. So we stated it was very low in our cohort. So we followed them up to 90 days with phone call and even in-person and follow-up for the patient. And basically pneumonia was less than 1%. So delayed hemothorax is more frequent than pneumonia, and then delayed pneumothorax is less frequent than delayed hemothorax. So 1% for pneumonia, pneumothorax, and about 10% for delayed hemothorax. We did show that the functional impact of minor thoracic injuries up to 90 days, and this impact was mostly related to the delayed hemothorax. So the one that gets the delayed hemothorax probably has a higher transfer of energy when they have the fracture, get a bit of complication, but still at 90 days, they don't perform as well as functionally as the other ones. We also show that the incentive spirometry. So who gives a spirometer or a recommendation when they discharge a rib fracture? So some of you
do it in the emergency room or in the floor, but we don't, I personally don't give that tool at home, which I think we should.
Yeah, in our setting, it's probably because I'm doing research, it was given regularly, mostly regularly to all patients at that time. So we have this in Emerge, and it's been given at discharge. So we followed those patients who had incentive spirometry. Obviously, we didn't catch if they were using it correctly or all the time, but still they were exposed and they had the machine, and it didn't really improve their complication rate, but didn't actually get the number of delayed hemothorax worse. So it's kind of a wishy-washy situation where we're not sure what to do with that, but there may be a couple of patients that need this spirometry and this spirometry, especially with some of the comorbidity that you can face as COPD or either CAD or CHF, and have a patient with rib fracture. So we need to further go down the road of the incentive spirometry eventually in a new phase that we're planning next year. But that's very useful as a tool for us. And it was one of the first publications from Emerge with spirometry, because all the other publications were on the floor following an surgical admission, basically. And also on the right down, you can see there's a risk factor for pain syndrome at 90 days. And those were actually related to number of rib fracture and the presence of smoking. So those patients were more high risk of having significant pain at 90 days from their rib fracture. So those are kind of the paper you can come up when you're deriving a rule, all of the spin.
And quick question: when you have those spin-offs, you actually produce them from the same data set that you got from your first, or you actually it gives you the idea, therefore you just go through another process?
No, actually it was already planned, most of them. I would say probably the spirometry wasn't, because we're not sure if the emergency physician would give it regularly in other centers. But the other one, the functional impact, was already embedded within the follow-up. There were questionnaire for that. So when you're doing clinical decision rules cohort, you obviously have to think, and that's where the discussion we had initially, you're looking at your clinical decision rule, your factors, what you need to put in, but you also have to think of the other question you need to answer with a big cohort, like 1,300 patients you're following, because that's a lot of resources. So, pain evaluation, follow-ups. So this was kind of one of the biggest studies that was done in Canada and even in North America, following those patients outside of the Emerge. So going back to the, any other questions? Sorry. No. So going back to the brain.
I actually have a question.
Go ahead.
Sorry. Might be a step ahead of your presentation, so let me know if so. Like you mentioned in the SAH rule, like some exam technique that are more vague, like neck stiffness and things like that. And it brought me to think about, in the Wells rule, most likely diagnosis. So when you have things that are more vague or exam sensitive, when you derive your rule or validate it, is there any specific treatment you do to that category of like the neck stiffness or most likely diagnosis? Or you just take your whole rule as a bunch and then you look at the sensitivity and if you're happy with it or not? Am I making sense?
Yep. So the answer will be that you need to do inter-observer agreement with some of the variables that are either, I would say, gray or a bit, I wouldn't say sluggish, but I mean, you may have different answer. So we do what we call inter-observer observation. It's where we call the reliability of the predictors. So technically, about 10% of your cohort, you need to have somebody else who's recording the same information on the patient, blinded, basically, to the first one. And then you compare. So obviously, if you're kappa, that's where the kappa type of thing you're going to see in some of the publication. If your kappa are not good for one of the predictor, you shouldn't keep it in the model initially. You shouldn't even get it in the model. And as for the Wells, we didn't publish, but I did present many years ago that we did the Wells blinded initially when it came up at our hospital. So I was seeing a patient with probable DVT, score the Wells, and then another staff would come in, do the same evaluation and score the Wells. And we did compare the Wells score, and it's a very good question that you brought here. And at our hospital, the kappa was 0.4, which is no good. It's you need to have 0.6 or more for an accurate inter-observer agreement. So we're not using the Wells at the hospital, because we proved that depending on the physician you see, the trajectory will be quite different.
Which means that you could use that like a formed rule already, like you did for the Wells. You have a rule that's been derived and validated, and use it in your own center and look at the kappa value and use it to see if you have a homogeneous community of physicians.
Yeah, you can do that. Yeah, the issue with the Wells is that it was developed mostly in an outpatient clinic setting with hematologists when you look at the detail. So probably had a different practice than we have. And that's why probably we're not as good as them for an homogeneous practice in the emergency department? And that's a good question, because when you're having a rule and you're critically appraisal the rule, you need to look at where it was derived, where it was built, and if it's similar to your practice. So if you have any difference that you can foresee as clinical decision, as the application of the rule, basically. When you apply the rule, you may see a difference in your practice. Then you always have to raise your flag and say, "Oh, we may not have a rule that's fitting for our practice here."
Great, thank you.
Similar to the question I didn't say, but like for the U-big, which we published, one of the issue with the U-big is that they do incorporate the moderate TBI within the same category of the mild TBI, the minor TBI, which is totally different for us in our practice. I'm pretty sure if you're working at Lake Shore and you got a moderate TBI, it's very unlikely you're going to keep it at your emergency department. I'm not sure if Lake Shore has neurosurgical, but I don't think so. But basically you're going to transfer them. So for some reason, the U-big that we are going to discuss in a minute were published with moderate and mild TBI, which is giving a mixed basket of patient for us, the application. We're mostly taking care of the mild complex TBI or minor TBI. So talking about the TBI, so we did publish something that showed the trajectory of the patient and kind of a variance in application and follow-up. So here on the left, you have the clinical deterioration of the patient. It was a number, the patient, the radiological deterioration, and the neurosurgical intervention according to a cohort patient. As you can see, there's very few patients that has a scan that deteriorates that go to a neurosurgeon intervention without a clinical deterioration. So patient-centered outcome are also very important when you look at a clinical decision rule. And probably the clinical deterioration and neurosurgical intervention are the one we need to aim for, and also obviously mortality. And that the deterioration of a scan may not be as useful for minor complex TBI. Even if the scan is a bit worse, but the patient is texting, walking around, going to the bathroom himself, it's unlikely the neurosurgeon will interfere and do any procedure. So we derive a rule, and this is unpublished work, so please do not take any picture because it's unpublished, it's new. It's been already discussed with the Ines, and Greg Clark also saw this technically. I don't know if he's on the call. So this is a rule you're going to see in the future. We have 3 candidate rules, but this is the best one we have. So the Quebec brain injury categories. So it applies to patients that are GCS 13. And as you can see, we're stating the application criteria very clearly at the beginning. So GCS more than 13, any scan, any minor TBI symptoms or signs, any bleeding on your CT scan, and you can take either or not anticoagulation and antiplatelet. So it applies to all your patients you see in Emerge. And basically, it's kind of a branching box. So first is subdural more than 7. It's quite a high risk. About 1/3 of patients will fall in that category. So it's quite less than the U-big for the U-big 3, but it's equivalent. 40% of them will either have neurosurgery or they will die from their brain injuries. And then the second category, which is moderate risk, that the initial Glasgow was less than or equal to 14, so 13 or 14, had a subdural more than 4 millimeter, but not greater than 7. They have contusion that's more than 7 millimeter and more than 1 contusion. Then it's a moderate risk where 20% of them will either have a neurosurgery or clinical deterioration. So they need to be at least observed for a while. 12 hours, not a definite cutoff, may change, and probably have a CT scan repeat. And then the very low risk, it's about 40% of the cohort. So remember that we showed that it was 10% in the U-big when we validated it. Now we're moving to 40% of the patient that can be dealt by us and followed and evaluated in the emergency department. And don't forget, you're working mostly in university affiliated center. But most of the patients that we see with this kind of injuries are in rural suburban centers. So having 40% of them not transfer and kept there with all the telemedicine we have right now could be very useful and efficient for our system. As for example, Antoine Saint Croix and Trois-Rivières wouldn't be transferring to our hospital or to Montreal while you're in Trois-Rivières. Sorry, I'm picking on you because you're in Trois-Rivières, because I know people in Trois-Rivières, but basically they will be kept there and evaluated if they're very low risk and observed.
They have a very good neurosurgical service over there.
Yeah, I'll have a call to Olivier Roy, the director in charge, which was my past friend here and colleague. Let's see if he finds the same thing. So this is kind of a rule that needs to be validated, obviously. It's been derived, and now we're validating prospectively, and you'll be, at Montreal General, Greg Clark is, I think it's up and running or shortly running. You'll be recruiting patients for this kind of project to validate this. So you won't see the rule right now. You will just be incorporating patient in your big cohort to validate this. So stay tuned for the next step. So very quickly, because we're dropping some of the rib and the minor TBI, just very quickly showing derivation. And derivation needs to be assessed, and you need to be very transparent and humble with yourself. So we did derive initially a clinical decision rule on shoulder dislocation, as you can see here. So, and it was published, and there were initially risk factor. Then we had a real rule that was published in 2009 and CGEM to assess who needs an X-ray when you come in. So most of the shoulder dislocation obvious. So do you need an X-ray or not? And that was kind of the rule you need to follow. And when I say you need to be humble, is that I'm going to show you what happens with a rule basically when you try to validate later on. But this kind of rule you can find on any of the publication if you want to follow it. But stay tuned for the next step, which is validation. And that's why you need to validate. So rules been prospective validated. Obviously, prospective validation in a different cohort, different time, same subject basically, with predictors that have been sound and robust. And then you have kind of refinement you can do. So the rule can still be at the validation state a bit refined. So one or two factor can be tweaked if you have many. Usually you don't redo the rule completely, but you may just refine some of the pathway. And that was still stated in 2014. So 99 recommendation top of the slides and 2014 at the bottom. So the SAH rule was validated CMAG publication here with about 1,000 patient. And we showed it was quite sensitive. We didn't have the specificity we hoped for. We're more aiming for 30%. So we're still avoiding about 15% of the scans from regular practice. But it was safe and validated and now could be applied at the Canadian setting or in population that was similar. It now has been externally validated. I'm just showing a couple of paper here in different places in Japan and in the States also. It's been published, so it can be used in other settings. So usually what's happen after your validation phase, it's externally validated by other team. So as coming back to our shoulder dislocation, sorry, we're going back and forth, like I said, like in Back to the Future. Oh, a couple of years after we published, actually 2 years after, in the same journal, somebody published that they failed the validation of the Quebec shoulder dislocation rule in an Australian emergency department. So it was actually, it was by, here as you can see the icon that was it looked like, because the same journal that accepted our rule accepted the failed validation the same. So it was a bit of a slap in my face, but I said, okay, let's go back to the drawing boards. So we did another kind of refinement cohort using also a friend of mine, Gregory Andy from Fresno, who's now the director of research at the UCSF University. So we use also cohorts of patients from him. So we do a prospective cohort study in 2 centers here in Quebec and Fresno, California. And then we came up with a rule that was slightly different than the other one for the age cutoff, but basically similar. So it was a refinement basically of the first Quebec shoulder rule, and I was called the Fresno Quebec rule. Some of you may have used it or not, and it's quite useful now with also the ultrasound that's available. It wasn't available at that time when we did it. It wasn't as popular, but you can avoid X-ray and just the ultrasound if you're following this. So basically, Very quickly, atraumatic recurrent episodes, no X-ray. It's really atraumatic and it's known for. And if age and greater than 35, then yes, probably you should consider an X-ray. And other mechanism, MVA, assaults, sports-related, important sports-related, and fall more than 10 feet. Those were all related to fracture dislocation, and you should do an X-ray beforehand. So you can reduce your number of X-ray by about 30% when you use the rule here compared to doing an X-ray to everyone. And as I show you, this has been now validated in many countries. So here are stating the Fresno, Quebec rule in Turkish on the left, which reduced about 50% of the X-ray. On the right, if I recall, was another African country. We also have in France at the bottom, where it's been shown to have the similar criteria as we have. So we've been now stated and validated for in many countries and can now be applied to your clinical setting. At the end, if you wish to have all the article I've discussed, I can do a link to a Dropbox for the presentation. If you wish, you can share it. Then I'm going to go very quickly on this. Those phases are less longer, and we're getting to the end of the clinical decision rule. Any question on phase 3 validation? No. I know it's a lot of stuff for 8 in the morning. All of you haven't absorbed your coffee yet. As you can see, I was up and awake earlier, so I'm fresh and can present you within 1 hour. As the rule been successfully implemented into clinical practice, that's where most of the rule gets a bit of a difficult. Getting funding to apply a clinical decision rule has been validated. It can be complicated because already if you're reducing your CT scan by 50%, you still need to prove that it's going to be applied correctly in a pragmatic clinical trial. But obviously funding for something that shows a very big impact, it's sometimes difficult to get it. As the rule been said, so clinical trial, either a pre and post, either a step wedge RCT or a simple RCT. There's many different ways of doing that, but you should prove that the common emergency physician is able to apply your rule, and it shows no adverse event basically, and it shows the effect of use. And it's accurate and it's acceptable also for the emergency physician. So just one quickly, and we're coming back to also a EBM teaching point, which is the SAH rule. Obviously, I showed you some are derived and validated, but not implemented, as you can see. From rib fracture, we're doing the implementation soon, I hope. But still, the SAH rule has been published. It was published in Stroke in 2020, where we had a pre and post evaluation, and it was implemented with a 6-hour computer CT rule. Sorry. So the rule was positive. Then you do a CT within the 6 hours, and if it's negative, then you stop there. And then after 6 hours, it was left to the attending physician for follow-up investigation. So Ottawa SAH rule, I think it's important to remember what I told you initially was the application criteria. So just you can see just under the title. So the Ottawa SAH rule is for alert more than 15 and non-severe, a new severe non-traumatic headache reaching a maximum intensity within 1 hour. And that's where sometimes the learner, even the colleagues of mine, apply the rule to the wrong patient. So if the patient has a headache for 3 days and is coming to emerge because the maximum pain just happened right now, so the maximum pain wasn't within 1 hour and the rule doesn't apply. So really it's a new severe onset headache and the maximum pain is 1 hour. That's the main question you have to ask before applying the rule. Was the worst of the pain in the first 60 minutes and you're presenting 2 days later on, or was the pain, indolent initially and then just, peaked to the roof once, like 3 days later? This is not a typical patient that we're looking the rule. And then you can see here the predictors have been validated. And obviously, this 6-hour CT ed rule do reduce the number of CT scan by a couple of percentage, and also the lumbar puncture needed afterwards. So it's good to apply right now, and it's been applied in the primary trial. Any question? That was the only one slide on 4, so I'd say I'm going quicker at the end. Yeah. Cost effective. Obviously, I will not show any studies, but you can see that it'd be very useful to show it's cost effective. Only the CT head scan and the Ottawa ENCODE rule have been shown to be cost effective in studies that have been funded. And how will the rule be disseminated afterwards and implemented? You usually now have the step before. So usually the step 6 is more like around 3.5 for we can, after validation, we plan on dissemination. So it's a bit of a change from the original one. So take to work points. CDR are created from original data and need to have at least a validated phase before clinical use. It can be applied to the specific population. Utility at bedside and support clinical judgment. And building robust CDR needs time and investment, as you can see. So it can be applied in clinical setting. So that's part of the. I still have time for a quick 10 minutes, or we're going over too long?
Considering that we started maybe a little bit late.
Okay, I'm going to go very quickly for the end, and I'll take some question very quickly for interaction. So building a clinician-scientist career is actually easier, probably, and it's like 1 or 2 slides here. So if you want to build a clinician-scientist career, it is possible in Quebec. When I just show you how many publications we can do and research we can do. So you need in your toolbox to have either a CCFP, EM, or a FRCP. A master is the minimum you need. Some do PhD, but I say a master is enough. You need to usually have a fellowship or a form of fellowship in research. We offer a research fellowship in Université Laval since 2017, I think. We have many fellows that came up our program here, so I'm just doing advertisement. So names you may have seen, we have Deborah Eagles, Christian Yadav from Ottawa that were in our program. We have also French from France that have been in the program. So we had 2 or 3 fellows and went back to France. So you need to have a form of training. With mentorship, so mentorship either locally or just putting here a network Canadian EM researcher where you can find mentorship also. You need to have EM services and department support, obviously, university support, a research center support, so a lot of support there, and a team. Obviously, building a team is an important aspect, and you need to have all those behind you so you can build a team of professionals that are there to help you, because you cannot do this alone. As an example, just give you an idea, at L'Enfant Jésus, we are 4 researchers right now. We have 12 dedicated offices that are only for research. We have about 8 full-time professionals that are different levels, and we have about 20 to 25 students overall working with us. So that gives you an idea when you get a team, what you can do and then move forward. So here's are the Quebec's milestone, and similar in Canada, but different calling. First of all, for either the CCFP, so the FMOQ or FMSQ, there is an agreement with the Ministry of Health that if you're able to prove that you're a clinician scientist, like half of the time, then you can take an agreement where you get money and your position is removed, c'est décompté, I don't know how to say it in English, but basically you're not calculated a number of emergency physicians, so they can hire another emergency physician to replace you, basically. So that could be a very good incentive if you're having a career. So aspirant chercheur at the bottom is actually for the CCFP one, because it's FMOQ driven with the ministry. So you'll have an extra position in your department for being a researcher, and you're going to remain extra if you follow the path that you see in front of you. So that's very interesting if you're a CCFP and you want to research. Those 4 years they give you as called the aspirant chercheur is time for doing a fellowship, finishing, starting career, building your CV, and then moving on to what we call Junior 1, Junior 2, Senior, and then at the top you have Chevronné, which I am, or Mérite. So those are all 4 years as for the term of your position. Different milestone I just put there as an example. When you apply for first Junior 1, you need to be able to show you can publish, right, obtain local funding, and you have a good research program. Roughly 10 to 20 papers already published, 50% as a first author. So that's when you go in the first step of a level 1. You can still do research. I'm going to show you next slide. You can still do research in Emerge without doing that path. But if you want to do clinician-scientist, this is the kind of milestone, and it's feasible. We have a lot. In Quebec, we have 7 that follow that pathway. They're emergency physician. Some of you may know. So we have Patrick Archambault, Bertolo, Saint-Onge at the Centre Antipoison. We have Éric Mercier, and Richard Fleet also from Lévis. So you're able to do that with a team and a support. So to give you an idea of where you need to go, I wrote the milestone here, give roughly, so you have an idea how you can move forward. You can still do your research, and that's part of my regular teaching I do with the academic level, roles in research. So I just discussed about the clinician-scientist, which is the producer on the left. So career as a clinician-scientist, usually it's a full-time, I would say full-time, half-time clinic and half-time research, 50%. I've been doing that since I started in 2004 at Enfant Jésus. So I'm doing like 2.5 days of clinics per week, and I do 2.5 days of research. You can be a contributor, so basically supervise research project. You can have a training in research. You can work with collaboration with other centers, but you may not do the grant writing and driving as a producer. And then the collaborator are quite important. So it's the on the floor recruitment of patient, also facilitate the research work. So either for scheduling, presentation, academic stuff that needs to be done. So it is the support there, but all this works together. All of those works together. Any question? Sorry, it was a bit quick at the end. Always available to answer question afterwards if you want by email. But it can be done. I know that I wouldn't say, I know at McGill there hasn't been a lot of EM researcher going that path so far, but I think can be done if you start early and have good mentorship. And I'm happy as an external researcher to help you navigate in this if you want. I have time to do that. So at the end, it's not always a gold paved road to do a clinician scientist, but you always end up being the Wizard of Oz somewhere in your studies. So question, you can send me an email if you want. I'm also putting a QR code if you want to know about the fellowship in emergency medicine research. You'll see if you want to scan it. I'm also going to make I'm going to send a link to Antoine, a Dropbox link where you have the articles that we discussed, most of them. And also you'll have the presentation also there. So you can share this with the one or here so they know about stuff. Sorry, I'm 10 minutes behind, but I think we started late.
It's okay. We'll deal with the consequences. I'm sure.
Oh, it's okay. I know
the
next presenter is Mathieu Gros, which I know very well, since I co-supervise him as a master's student. So you just need to crunch it in 20 minutes.
All right, Mathieu, you got this.
I'm not alone, actually.
Okay, well.
Yeah, that's the thing. There's Harish too.
Yeah. So Mathieu, you only have 10 minutes. You're not alone.
It'll be rough. I'll try.
So I'm gonna stay until the end and until the break, and listen to your journal club. But feel happy to send me an email. I may not answer right off the bat, but usually answer within the first couple of days of your email.
All right. Well, thank you very much for your time. Your presentation was actually great. I think it answers a lot of questions we had about research and more especially about clinical decision rules. And yeah, thanks. I think it was a very good idea of Dr. Grant to actually invite you. So our next presentation will be actually a journal club with Mathieu and Harish, who are both FRCP residents. And it will be about the use of DSD in VTAC cardiac arrest. All right, guys, the floor is yours.
Thanks a lot, Antoine. For those who don't know me, I'm Harish. I'm one of the new R1s that joined the program. I'll just share my screen now. Can everyone see that?
Yep.
Perfect. So Matthew and I will be presenting our journal club today, as mentioned. I'll be presenting the article, and then Matthew will go over the role of systematic reviews in research. So the article we're doing is dual sequential defibrillation for refractory ventricular fibrillation cardiac arrest. It was a systematic review. It's published in October of 2020 in the Resuscitation Journal. So quickly to go over the objectives, we'll discuss the background and technique of DSD, the aim of the paper, analyze the methodology and results of the systematic review, and then some of the limitations of the paper. So going to the background, VFib and pulsus VTAC have shown to have higher survival probabilities compared to non-shockable rhythms. And in these patients, time to defibrillation has been shown to be a major determinant of treatment success. But 10 to 20% of patients don't actually respond to the initial shock and require subsequent shocks, but this is also associated with worse outcomes. So DSD has gained popularity in recent years as an alternative to treatment options for patients who fail to respond to standard defibrillation. It's actually discussed in the American Heart Association guidelines. However, in the guidelines, it actually notes that its usefulness has been yet to be established. So what is it actually? So like the name implies, it uses two defibrillators in tandem. There's two possible positions you can use. The first one, your first defibrillator is in your anterolateral position, and your second defibrillator can either be in your anterior posterior, as seen in the image above, or in your adjacently anterior lateral, as seen in the image below. So the two defibrillators then give shocks in rapid succession, and the goal is to deliver both shocks at the same time or deliberately have this small pause. So there isn't actually a uniform technique as seen. You can place it in different positions, and the shock timing can also vary. Proposed mechanisms is that alternating energy vectors are applied, you have increased energy dose, or the time between the sequential defibrillations decreases the impedance threshold required to shock the heart adequately. So the aim of the paper, despite this increased popularity, there is limited evidence on the effectiveness of DSD. There was already a 2019 meta-analysis performed that concluded the effectiveness of DSD remains unclear and that further prospective studies were needed to determine its role in treatment of refractory VFib. Since then, there were several new studies that were published. So the aim of this paper was to conduct another systematic review incorporating the new studies and examine the evidence for the effectiveness of DSD. Should be mentioned that it was commissioned by ILCOR's ALS task force. So getting into the methods, it was registered with Prospero and reported in accordance with the PRISMA guidelines. 3 databases were searched, Embase, Cochrane, and Medline via PubMed, and they were all searched from their inception to February 28th, 2020. They used a comprehensive combination of different subject headings and keywords for the 3 concepts of defib, cardiac arrest, and patient outcomes. They also looked at various clinical trial registries to identify any ongoing research. And finally, reference lists of any key articles or hand search so they didn't miss any key articles. No language limits were applied. Regarding selection criteria, adult patients with a shockable cardiac arrest rhythm in any setting were screened or papers with these patients. It included randomized and non-randomized controls, as well as observational research studies. They excluded case studies, case series with less than 5 cases, any conference abstracts, protocols for clinical trials, and studies without the actual points of interest. Regarding the outcomes of interest that they looked at, termination of VFib and pulsus VTAC were one, ROSC was another important, survival to hospital admission, survival to hospital discharge, survival at 30 days or greater, and finally, good neurological outcome. Regarding paper review, did 2 reviewers independently screen articles and abstract the data, and discrepancies were first resolved through consensus between the 2 reviewers, and if required, there was a 3rd reviewer. Kappa statistics were calculated for the abstract and full manuscript review, and then risk of bias was calculated using the Robbins I tool used for observational studies and the Cochrane risk of bias or ROB2 tool for the clinical trials. The overall certainty of evidence that was reported using the GRADE guidelines. Please let me know if I'm going too fast. I have a tendency to speak really fast, actually. So regarding article results, initially 314 articles were identified through the 3 databases. Duplicates were 174, so these were excluded, leaving 130 articles to be screened. At the screening stage, 120 articles were screened out and with the kappa of 1. So there was 10 articles for the reviewers left to fully review. At this stage, there was 1 article that was removed because it was a secondary analysis. So the reviewers were left with 1 pilot RCT, 4 cohort studies, 1 case control, and 3 case series. This left, forgetting exactly how many patients. If I can find that, I think it was 1,581 adult patients, of whom 326 had DSD applied. So I put this up. It's the table of the characteristics of each study. There's a few points to kind of point out because it really already highlights some of the limitations. First of all, the pilot RCT had a very small sample size of only 91 patients. And 3 of the 9 studies were only case series with only 7, 10, and 12 sample sizes, so quite small. And if you look at DSD technique, you can see that they were actually applied at different points for each paper. So there's already significant clinical heterogeneity. When they looked at the risk of bias using the tools, it was found that 6 out of the 8 observational studies actually had critical risk of bias and 2 had serious. It was predominantly because of not adjusting for confounding variables. Several studies also had significant selection bias and few had quite a bit of missing data. When they looked at the randomized control trial, it was deemed as some concern for risk of bias, and this was predominantly because of deviation from intended intervention.
Arish, I think there was a question before you go to the next.
Yeah, can I ask you a question? If you go back to your slide of the description of the cohort, when you're analyzing just the kind of EBM stuff we're discussing here, but when you're looking at those numbers and you're saying, okay, they're small, but you always have to relate to the type of pathology you're looking at. So how many of you have seen refractory VTAC every day,
Yeah.
So even 91 is actually more than I've seen in my career when I started working in 2000. So I don't know the other staff, but it's still a lot. Obviously 7 and 12 are very small, but even 91 is a pilot RCT. I do believe it's it's worth the effort of the researcher. It was a kind of a common thing that we always have to relate to the prevalence of the pathology that we're seeing.
For sure. Thank you for mentioning that. Actually, it's not something I considered. So I will get going. There you go. So now we looked at they looked at each clinical outcome for neurological function. We'll start off. So they found very low certainty of evidence from 5 observational studies. Ross et al. Was a cohort study in 2016, and they found about 6% of patients with DSD had good neurological function outcomes compared to, I believe, 11.9% with standard defibrillation. And MAP et al. Was a case control study that showed about 12% compared to 19.4% with standard defibrillation. Neither was statistically significant. And this can be seen by the fact that the confidence intervals crosses the risk ratio of 1 here. So you can see this in the forest plot. The last 3 studies that aren't here were all case series, and they showed good outcome with 0%, 16%, and 28% with good neurological outcome in the case series. When they looked at hospital discharge, none of the studies actually were statistically significant. However, they found very low certainty of evidence from 5 observational studies and had a total of 947 patients. Emerson et al. Favored DSD slightly with a survival rate of 6.7% compared to 6.3% with standard defibrillation. With hospital admissions, once again, they found very low certainty of evidence from 5 observational studies, and Emerson et al. Again favored slightly with 22.2% compared to 19.4% with standard defibrillation. However, once again, it was not statistically significant. With ROSC, they actually found low certainty of evidence from the 1 pilot RCT and very low certainty of evidence from the 6 observational studies. Beck et al. Was a cohort study that did find that there was significantly decreased risk of odds with ROSC with DSD compared to standard defibrillation, with 39.4% with DSD compared to 60.3% with standard defib. However, there was a follow-up RCT, or the pilot RCT in 2020 by Chesk et al. That favored standard DSD, with 40% compared to 25% with standard defibrillation. However, it was not statistically significant. The final clinical outcome they discussed was termination of VFib. They found very low certainty of evidence from 4 observational studies and low certainty of evidence from the 1 pilot RCT. In the cohort study by Chesk et al. In 2019, a reported a termination rate of 76.5% with DSD compared to 78.1% with standard defibrillation, favoring standard defibrillation. However, their follow-up randomized control trial showed a termination rate of 76.4 with DST compared to 66.7% with standard defib, favoring DST a little bit more. However, once again, not statistically significant. So I know that was a lot of information at one go. So just to summarize the results a little bit, there was low to very low certainty of evidence from the use of DST in all assessed clinical outcomes. And the use of DST was associated with variable results in all the outcomes. There was no additional evidence to support its use in routine clinical practice compared to the 2019 meta-analysis. And most studies included had a critical risk of bias due to lack of adjustment for potential confounders. I've already kind of highlighted some of the limitations, but to go through them, first of all, there's quite a bit of selection bias. You had 3 case series. Meta-analysis wasn't performed because of the considerable clinical heterogeneity. This included inconsistent applications of DST and its technique, including pad placements, energy dose, and a lack of uniformity in the technique. Also, I mentioned earlier, timing kind of varied across all the studies, and most studies used it quite late in resuscitation attempts, so suggesting a pretty strong possibility of resuscitation time bias. Final limitations, there was no uniform definition of what was refractory VFib in the studies. They didn't report on ACLS interventions that were used, so this is a potential confounder. And there was limited details on definitions. I talked about good neurological outcome, but the systematic review didn't actually establish what that entailed and if it was consistent across all the papers. Finally, they didn't review greater literature, additional databases. Me and Mathieu mentioned this because there was a previous meta-analysis just a year prior. So given this was done quite soon after the fact, it may have been prudent of them to expand their search a little bit more. So that brings me to the end of my review. I'll hand it off to Mathieu to discuss systematic reviews.
I think you need to stop your screen sharing so I can share mine. Here we go. So you all see my slides? Assuming yes. All right. So I think it's no.
Wait, it's I think it's maybe, is it just me, or I only see Mathieu Gros has started to share screen?
Yeah, no, Mathieu, we're not seeing it. We see you've started it.
Try again. Try again.
Yeah.
Okay. It's a bit weird. Just give me another second. I'll try this.
Oh, boom. It works.
All right. I'm just wondering because it's not how I share it normally. So do you see me changing my slide, or is it?
Yeah, it's changing.
Okay, perfect. All right, sorry for that. So thank you, Arish, for this lecture. So I think it's a good opportunity to review a bit what are systematic reviews and what's the methodology behind those, as you have just presented one to you. So you probably all saw those pyramids representing the hierarchy of science evidence in many textbooks, and whatever version you're looking at them, the kind of paper we always see at the top of this pyramid are the systematic reviews. So we'll see why. First of all, systematic reviews, just like any other science paper, they tend to answer very specific research questions, and also there's a methodology behind them. And what makes systematic reviews unique is that their goal is to assess all of the relevant studies answering your specific question. So when you read a systematic review, you should be confident that what you have within your hand is all the published data that exists to answer your questions. So this is why it is at the top of the pyramid for the hierarchy of evidence. Meta-analysis, they're not always performed with systematic reviews. It will always depend on your heterogeneity and if you can pull all the studies together, but it's just the statistical analysis of all your data. So you can pull all the results from the included studies and do inference from them. Sorry, the word is not coming out. All right, so we talk about systematic reviews. Actually, not to be mistaken with other kinds of literature reviews. There are different kinds and they don't have the same values in terms of bias. They are absolutely not all at the top of the hierarchy of scientific evidence. there are different kinds. As you can see, they all have different risk of bias, and they don't take the same time to perform. I'll go on the next slide. I have a few definitions. So what most researchers would publish are often traditional or narrative reviews. So this is done by researchers who are experienced within a domain, and they will just present the known literature on a topic. So often if someone is searching literature before doing an RCT, while they build their intro, they might also, on the other side, write another paper, which is their narrative literature. The danger with that is that there is no formal methodology that is expected when you build this kind of review. So when you read a narrative review, it's biased and it is bound to the experience of the person who wrote it. So you're not confident that you really know everything about your topic. There are other kind of reviews. We don't see often scoping reviews, but this is quite interesting because it's a bit like a systematic review, but instead of saying we think that the intervention is harmful or that the intervention is beneficial, you will have ask a result that there is, for example, no RCT on a certain topic. So it shows the gap in evidence or the gaps in research. So it takes not too long to do because you don't have to analyze what is in the included studies. And the most the most complete kind of review is, of course, the systematic review. As I said, the goal is really to retrieve all of the evidence, all of the data answering a specific research question and to analyze it. And you cannot do it by your own. You need to be at least two researchers so that you can make sure that you have good reliability within the selection of your articles. And it takes way longer to do compared to a narrative review. So it's a process that goes from months to years. So how do we do that? Well, first of all, as the goal is to answer a clinical question, the success of your systematic review will rely on your search strategy. So this is extremely important. You need to really take all the time needed to build a very strong strategy. According to the Cochrane handbook for systematic reviews, they suggest to look at least into 3 databases, which are Medline, Embase, and Cochrane. I think we all know Medline. We often search it through PubMed. Embase is actually a bit quite broader, and it's more sensitive if you're looking at anything related to drugs. And fun fact, Embase includes everything that is in Medline since 2010. So why duplicate the work and look into those 2 databases while technically Embase includes Medline? Well, the search strategy is different from those 2 databases. So with Medline, you will use the mesh terms. With Embase, you will use the M trees. So it's possible that for example, in a paper that should be included would be retrieved through both of those databases, but your search strategy will be sensitive only for one of those 2 databases. So this is why it's important to search Medline plus Embase. And also if you want to be complete in terms of systematic review and clinical trials, you should also search into a Cochrane database. Also, you might need other databases or index tools such as Web of Science, Scopus, PsycInfo. Really, it will depend on what you're looking at. And I think the best strategy would be to sit with a specialized librarian and to see with them what are the pertinent databases, or to sit with an experienced researcher in your field who knows exactly what to search. And I see that Marcel Emond has raised his hand.
Yeah, sorry about that, but I don't want to introduce a lot. Just to give numbers to the resident or doing this kind of study, Embase and PubMed, usually you find 30% different articles when you do the both search. So it's worth it to do both search. May not be as so in the last years because they've been kind of merging more, but initially was like 30% more. I would say different, let's say not more, but different articles.
Thanks for that. And also a word on GUI literature. So as Arish said, it's a bit disappointing that the systematic review I've just presented you did not include it because it's not mandatory, but it's highly recommended to look at it because most of the research is not published or is not published in index journals. So it's possible that, for example, government authorities or pre-hospital authorities will conduct their own research and they might publish them on their website, but you will never find it if you look only in Embase and all the other official databases. So it's worth a try. I mean, you don't need to analyze the millions of results from Google or Google Scholar, but sometimes what you can do is like to say that you're going to look for like first 100 or first 1,000 results that come from, for example, Google Scholar. So, but as I say, it's not mandatory, it's just highly recommended. So as for clinical trials, it's always good to publish your protocol prior to running your study. So that's a good way to make sure that what you do is reproducible. So this is the protocol that was published in Prospero from our study. So we see like the PICO question, and all the rest is quite of similar as what was in the final paper. So just out of curiosity, I looked yesterday how many protocols were registered for systematic reviews on a double sequential defibrillation. Actually, there were 6. The one in purple is the one that we've presented you, so that we see that there is one that was recently registered, and they want to potentially do a meta-analysis. So we'll see if there's something interesting coming out in the next years. So once you have done your search strategy and that you've published it, you can now run it in the databases. So at this step, you need to be 2 reviewers, and you'll just merge all the included studies, remove duplicates. You'll look at title and abstract as a screening part, and then you will have full text articles that you're going to assess and decide if they meet or no the inclusion criteria. Here it's interesting, they reported the CAPA, so the inter-reviewer reliability. It goes from -1 to +1. So +1 means 100% of être en accord, so to have the same decisions. So that's quite impressive. But didn't have that much paper to analyze. So. And if you don't agree, so if the 2 researchers, one says, I would include this paper, and someone else would say, I would not include this paper, then you need a third party. So Marcel was the third party in my systematic review, but we didn't have to call Judge Judy. We were able to, through consensus, to decide what would be included or excluded. So
I will send you a new picture because this one is not reflecting myself.
Thanks. So that was the easy part, what I showed you. Anybody can do it. You don't need any background. Any monkey could do it. This is the toughest part, is to determine what is the quality of your evidence. So you need to understand if what you have within your hand is good studies or biased studies. So yes, tools are there to help you. There's the Robinson I, the RUB2, there are others also tools that can be used. But what is difficult is that the papers included won't tell you, oh, by the way, we did selective reporting. Oh, I think we have major confounding issues within our studies. Okay, so you really need to have a head over your shoulders. So this is where judgment is needed when you do your systematic review. And I think this part, it's a very small table, but is one of the most important and the one that takes most of the time within your research. So after that, you'll decide do you do a meta-analysis or no. So you'll look, do you have similar studies? So you're looking at heterogeneity. 2 types of heterogeneity. First one is the clinical heterogeneity. So are there differences in the design, population, intervention outcomes? So this is how you analyze it. So you look at the study designs, you look at the difference within the protocols, or like here just a picture of their sentence about clinical heterogeneity. So they reported that ACLS interventions were not reported. They could have also reported like provinces and countries doing the study, because we know that pre-hospital protocols are not the same within different settings. So at this step, they decided not to do a meta-analysis. You can have similar studies with similar designs and still have different results. So this is what is called the statistical heterogeneity, and is reported through the forest plots. So as we can see here. So on the left plot, we see studies that have low heterogeneity. Why? They all show benefit, and some of them are statistically significant. Some are not. Maybe they're just underpowered, but they all show pretty much the same. While on the right side, you have statistically significant studies showing benefit and harm. So this is a bit, this is not reassuring when you believe that those studies are assessing the same population within similar designs. So there's probably something that is not reported, and maybe they're missing subgroup analysis, or maybe they have had a selection bias, but there is something that is wrong and you cannot do a meta-analysis. Also at the bottom of your forest plot, you will have two values reported. There's the chi-square and also the Higgins or the I-square. The last one is the most sensitive, and just as a rule of thumb, if you have over 70% of I-square, you should not perform a meta-analysis. 100% would mean that all the difference are attributed, to heterogeneity, while the 0% would be only to chance. Finally, you might have similar studies included. You might have no heterogeneity, but your result can still be biased from the publication bias. So it's possible that you have retrieved every data published on your topic, but it's possible that not everything was published. So we all know that small studies tend not to be published compared to bigger ones. So you can use the candlestick, but what we see more is the funnel plots. So if you look on the left one, this is an example for a unbiased selection from your study. So at the bottom of the triangle on the y-axis, on the left of the x-axis are the small studies, and on the right you have the study with bigger population. And while you go up on the y-axis, you see, when you go high on the y-axis, you see larger studies. So it's normal that your effect is kind of at the midline. And when you go down on the y-axis, on the left, you see small studies showing less benefit, and on the right you see small studies showing more benefit. So you should have the same amount of small studies showing less and stronger effect. So when we look on the right triangle, we see it's kind of truncated. So we would be in that situation, missing smaller studies showing less benefit from the intervention. So you could assume that some studies were not published. So yes, what does it mean is that your meta-analysis would wrongly suggest a strong benefit, while the benefit could be reduced. Just concluding with this, garbage in, garbage out, we often see this sentence with systematic reviews. It means that you might have the most perfect methodology, the top researchers, but if all the included studies are low quality evidence, your systematic review is low quality evidence. It will not support the use of the intervention. So just to keep in mind that it relies on the quality of what is included. And also there's a tendency within the last decades to publish more systematic reviews over single randomized controlled trials. Why? Well, it's easier to do. And it's very interesting for new investigators to do systematic reviews, because it doesn't mean a lot of financial support. It only takes time. And it's a good opportunity for researchers to get familiarized with the topic and get specialized with a specific question. But there are still good sides to systematic reviews. It's possible that you will find 50 good randomized controls that were a bit underpowered, and by pulling all the results together, you might be the first one finding that statistically significant result. And also, it's always good for writing guidelines to have systematic reviews to sit on. So this is it. I hope I didn't take too long. So thank you, everybody.
Good job, Mathieu. Good job, Harish. Is there any questions? No. There's Dr. Emond who is applauding your presentation. All right, then if there are no questions, we'll take a 10-minute break, and we'll reconvene at 9:50 for the next presentation. And thank you again, Dr. Emond, for staying this extra time. You are for sure welcome for the rest of the presentation, but we understand you're a very busy man.
Yeah, I have to go on the beach behind me.
Then
See ya.
enjoy.
See you next time. Bye-bye.
Bye.
Oh. All right. So our next speaker is Dr. Brisebois, who is just connecting. Hey.
Hi, everyone. Sorry, I'm on shift. Sorry.
So you weren't able to get a switch finally?
No, not. It's okay. Yeah, they're gonna survive for a few minutes.
Well, thank you.
No worries. All right, so I'm just gonna share my screen for the presentation. 1 second. Perfect. Can everybody see the presentation?
Yes.
I'll just go start the slideshow. Hopefully it's gonna work. Perfect. It's working.
Yeah.
So the goal today is really to talk about gallbladder ultrasound. Every few years we talk about it again. It's actually very easy to do, and it provides a lot of information that are very relevant to the patients we see in the emergency room. So really the objective today will be to go over the technique, how to identify the gallbladder properly, how to look after that for gallstones, no gallstones, and then signs of cholecystitis afterwards. There's a few troubleshooting techniques that are important to know as well. And how is it applied to the emergency room department? So the first questions to answer once you're able to identify the gallbladder is there stones or no stones? If there's no stones, from an emergency room perspective, we're not necessarily going to go look for acalculous cholecystitis. So at that point, we're just going to essentially stop looking we're going to rule out that the gallbladder is the source of essentially the presentation of the patient. If there's stones, then after that, look for signs of cholecystitis. So either the presentation is consistent with biliary colic, or possibly could be an inflamed gallbladder. This is where there's other findings that will help you make the diagnosis. So the gallbladder is nice because it really helps you test your POCUS skills. The gallbladder is a very variable lie, so it's never exactly at the same place for any individual, but it's oftentimes very superficial. So the most common mistake is that we tend to look a bit too deep, but it's a very, very superficial structure. In the emergency room, most patients maybe did not come fasting. If the patient ate not long ago, a contracted gallbladder can be very difficult to diagnose. And also, sorry, I hope my connection is okay. And also, the thickened wall of a contracted gallbladder can sometimes lead to a mistake of thinking there's cholecystitis. Bowel gas will obscure the gallbladder, and there's a lot of little artifacts that can essentially make the assessment of the gallbladder difficult. Patient body habitus, that's a limitation that we always have with ultrasound, that radiologists will have as well. So we have to trust our technique and trust our troubleshooting maneuvers to try as much as possible to assess the proper structures. There's a few things we can do with the ultrasound to make that easier. So we're going to use a curvilinear probe or cardiac phased array if we have to go in between the ribs. The goal is to use a very low frequency probe. Now, on most machines, you can actually change the frequency. Most machines will have like a frequency button that you can press at least 3 times. There's presets that goes to either, you'll see essentially it varies, but there's a low frequency setting and a high frequency setting as well. So you usually tend to move from general and go to low frequency. That will help you go see through fatty tissue. So somebody who's a bit more obese, you can actually preset your probe to look for more fatty tissue. The first step is after the patient's if you can, the patient's mobile, like having a gallbladder, but you can and then heal the procephalad. Okay, once you heal the procephalad, the goal is to assess the liver edge, and you're only going to truly see the gallbladder through the liver. So if on your screen you don't see the liver, and you just see bowel gas, it's doomed to fail. So move the patient directly to the left through the liver. Here the probe is sealing cephalad, and then we're going to move. And the gallbladder can be all the way to the anterior axillary line. So really slide your probe laterally. Once you hit the anterior axillary line, you know that there's no point in going more lateral than this. You won't see the gallbladder at that point. So move 1 rib space above or have the patient turn on the left lateral decubitus. So this is just an image to show how the gallbladder can have multiple lives. So the goal is not to have the perfect view of the gallbladder initially. It's to identify a structure that's superficial. Then we're going to confirm that that cystic structure is indeed the gallbladder. And to do that, you need to be able to, point sign is the relation to the point, the main location that only depends on how the gallbladder is, the lie of the gallbladder, but you need to identify the exclamation point to say that this is indeed the right structure that I'm looking at. It's not a piece of bowel that's filled with liquid. And once you see that, then you can confirm this is a gallbladder. This is an example portal vein is very characteristic in the liver. It has very echogenic walls, the portal vein, and look in the vicinity of, here we have the MLF. Sometimes you only see the MLF linked to the portal vein and gallbladder as you sweep, and you'll see the relationship. And then here we have the gallbladder, we connect in the fundus. This is a long axis view of the gallbladder. So once you see that structure, rotate your probe a bit to try to get that perfect long axis view of the gallbladder to assess it and then sweep. Okay, so this is essentially a short axis view of the gallbladder. We see here the portal vein, we see hepatic artery and the CBD. Together, essentially we call this the Mickey Mouse sign. You can technically assess the CBD to see if it's dilated or not. You could put flow to see where's the flow. There should be flow in portal vein, hepatic artery, but not in the CBD. So if you cannot identify a cystic structure and say that, oh, okay, this is my gallbladder, first thing to do is left lateral decubitus. The bowels will sink away from your probe. The gallbladder might swing forward a bit and will be easier to appreciate. You can either also ask the patient to take a deep breath in. By taking a deep breath, liver will come down with the diaphragm, and then you'll have a better window to see everything. Okay. The opposite of that, if the patient cannot hold their breath, is to take your probe and go cephalad. So essentially, you'll go intercostals to really use the liver as your window. And if you do that, you can still use the abdominal curvilinear probe, but the phased array probe is a good probe to go in between the ribs, and you'll still see a very good view of the gallbladder. I tend to use the cardiac phased array probe a lot to look at the gallbladder and go in between the ribs, especially the more like gen dead patient, obese patient that can't really move around. And then the last approach would be a lateral approach. That's more of a rescue view, where you trigger the same view as you look for free fluid in the right upper quadrant, but then you just slide your probe anterior or you sweep anteriorly. And usually in the Morrison's pouch, anteriorly, between the kidney and the liver, you'll see the gallbladder appear in that location. So first, have a look at the gallbladder long axis, then rotate your probe 90 degrees and have a look at its short axis. Span through the gallbladder both times. And then your first question is there stone or no stone? Something to be aware of is you'll often see the duodenum in that location. And the duodenum, if it's filled with liquid, can sometimes look like a gallbladder filled with bile. So if you see, this is a classic, essentially, gut, if you want, how it looks like. This is where the duodenum is. If you see peristalsis, then you know this is gallbladder.
The connection.
And also, sometimes people can view, so put flow. The gallbladder should have no flows. Is it better now?
The
I hope so. Is it better?
Connection did lag
for a minute. Yeah, it's because I'm probably using my hotspot, so I have to touch my phone a few times.
So you said what to do with
peristaltism. Then yeah, so look for flow and peristalsis. Okay.
Flow also.
The gallbladder should have no flow, and the gallbladder should not have peristalsis.
Okay.
So first question, stones, no stone, sweep. Okay, a stone for more than 4 millimeters should cast a shadow. Look for a shadow. Look for a hyperechoic mass inside the gallbladder. Now, notice here the stone is really in the gallbladder neck. Something that can sometimes cause a false positive is the edge artifact. The edge artifact would be an artifact coming from the lateral sides of the gallbladder that can look almost in the same place that where the stone would be. And this is why it's important to look both long axis and short axis. So for example, this is a gallbladder, and here you can see a large shadow, large stone. And so that answers the question that there's a big stone. So that patient could be very well symptomatic from biliary colic. Here again, we see a stone, small shadow, near a bit the gallbladder neck area. Again, so notice how the edge artifact is at the end. And if depending on let's say the gallbladder was vertical, it could be quite confusing to know if this is a stone or not. Okay, but here again, very quick walls shadow, we have a stone roll in the gallbladder often. Multiple small stones are sometimes tricky. They'll cast a very wide shadow without necessarily seeing the nice cortex of the stones. So the shadows are a bit your clue that there's something abnormal. And the porcelain gallbladder, you won't initially see the gallbladder very well. It's just going to be one hyperechoic line with a whole shadow that represents the gallbladder. So a porcelain gallbladder is actually very difficult to visualize until you understand that I'm not seeing the gallbladder as I expect as a cystic structure because it's casting such a big shadow. So for example, here's multiple small stones in the gallbladder casting a bunch of shadows. So we call, if there's a lot of stones or large stone, we call this the wall echo sign. Okay, the wall echo sign, essentially, if you see this gallbladder, it's one big stone. So essentially, it's the whole wall of the gallbladder that casts a shadow. So you have to differentiate that from a porcelain gallbladder. Here we can see that in one of the views, there's maybe a bit of bile around it. You can kind of see the wall of the gallbladder. So you know it's not the wall casting a shadow. There's really an object within the gallbladder that's casting the whole shadow. But this is one of the most difficult things to diagnose sometimes because it doesn't necessarily look like a proper gallbladder. So you have to keep your eyes peeled for that. The edge artifact, this is an example where the edge artifact combines with the acoustic shadowing to kind of obscure is that truly a stone or not. So rotator probe, short axis, long axis. The edge artifact will always remain on the edges of the gallbladder, whereas the stone essentially in the short axis here will be in the center. And you should see that nice acoustic shadow telling you that there's something in the neck. So be careful with rib shadows as well. And then once you diagnose that there's a stone, look for signs of cholecystitis. So the next step is really to look for a sonographic Murphy. If you have a positive sonographic Murphy with a stone, you essentially made your diagnosis. Okay, so have the patient take a deep breath in and just press on that gallbladder, and if they hit you, then you have your diagnosis. There's other findings that can go along with cholecystitis, but really in the emergency room setting, they should have pain on palpation of the gallbladder, especially with a probe. So you should have a positive sonographic Murphy. And I would not necessarily call a patient with a cholecystitis without having pain on palpation of the gallbladder. The other findings that you can see with cholecystitis are important, but are secondary. So gallbladder wall thickening, there's a differential for that. Pericholocystic fluid, there's also a differential for that in gallbladder distension. So here is an example of cholecystitis where you can see the thickened wall. It looks a bit fuzzy, not well delineated. This is actually a nice cholecystitis, and you can see the stone actually present. I expect this guy to have, or this woman to have, a nice sonographic Murphy. This is an example of a patient who just ate before coming to the emergency room. So the walls are not as fuzzy, but this is a contracted gallbladder. So you can see how it's well delineated. The clue here is that it's not distended. I would expect some kind of distension if there would be cholecystitis. So As a general rule, gallbladder distension is one of the signs of cholecystitis. This gallbladder is contracted. So that's a normal gallbladder with a thickened wall if you measure it. Any walls more than 3 millimeters is considered to be thickened. And this is a differential of gallbladder wall thickening. So several things can cause that, but again, go with the clinical picture. Here is pericholecystic fluid, very subtle, around the gallbladder. You can see the posterior wall here, a trace fluid around it, and also in the interior, like a lower at the edge of the gallbladder. Now, pericholecystic fluid, you'll see it with cholecystitis. It's actually the most specific sign. However, if you look at the gallbladder a lot in your patients with CHF and minimal ascites or hepatic congestion, oftentimes you'll see a bit of pericholecystic fluid, or in your patients with pancreatitis, just from irritation, you'll see a bit of pericholecystic fluid. So really take that into context. Expect, again, a sonographic Murphy, and make sure you see a stone. This little guy here is a little polyp. So you might see this and think, oh, maybe there's a stone, but the clue here is there's no shadow, so no calcification of that polyp. And if you had the patient move from supine to, let's say, lateral decubitus, it would remain exactly at the same place. Now, some polyps have to be followed, some of them don't. For this patient, essentially, I would refer him for follow-up as an outpatient, either have a formal ultrasound. Now, Up to Date has a nice table that tells you that a polyp less than 3 millimeters don't need any follow-up. So if you would measure it and you're within that range, you could just forget about it. This is a view of sludge. So sludge really looks like mud, essentially, within the gallbladder. And that also sometimes you can see some calcifications or some stones mixed in with it. So make sure you fan, and this can also be associated with cholecystitis. This you might see from time to time. It's fairly common not to think it's a polyp, but this is a fold. It's really just the gallbladder folded upon itself. So if you see this, this is completely normal, okay? Troubleshooting maneuvers. So remember, left lateral decubitus is actually your best friend. And if you can go start with that, it will make your life much easier. You can go in between the ribs. Here, he's transverse in between the ribs. I would actually go still longitudinal first and then rotate my probe afterwards. And this is the rescue view of the lateral approach, where you trigger Morrison's pouch view, and then you sweep your probe anteriorly or sweep anteriorly your probe. So in your patients, in terms of emergency room, anybody presenting with epigastric pain, especially in the middle of the night, nausea, vomiting, some people with chest pain, when you look at the heart for pericardial effusion, you can look for pleural effusions at the same time. It takes 2 seconds extra to just have a quick look at the gallbladder and see if there's a presence of stones or no stones. And that can change essentially your differential quite a bit. Now, if you see signs of cholecystitis, depending on your surgeons, it happened a few times that some surgeons were okay with the clinical findings and the ePOCUS to admit the patient. If you just have a diagnosis of biliary colic, usually I'll give them an outpatient ultrasound and an outpatient surgical consult. So they'll follow up the results of their formal ultrasound with the surgeon, whoever, when they see them in 3-4 weeks, to plan for elective surgery for their symptomatic biliary colic. Any questions?
So there's Anne-Sophie in the chat who says, do you have a buy-in from surgery to skip the formal echo?
You just replied, kind of.
It depends on your surgeon. Every surgeon is a bit different. And hopefully as we move along and more surgeons get trained in ultrasound, at some point they might even do their own ultrasound and confirm before they go to OR. It's more of it really depends on the surgeons and how's your relationship with them.
All right. Me, I was wondering, I think I maybe just missed it, but when you were talking about the gallbladder distension, is there a number?
Yes, so sorry. So gallbladder distension essentially in the long axis, think of your hands, 10 centimeters, okay, and short axis, 5 centimeters.
Great.
would be the cutoff values.
Right. And if there, so so yeah, so Kevi was saying that the on shift and hotspotting is impressive. My other question is more about ultrasound in general. Usually, because you were talking about the little polyp in the gallbladder, if we ever see something that we're not necessarily trained to see, but that looks odd, what's your way of investigating it? Do you just do a formal ultrasound and see what they say, or you actually go through a scan, or like?
So it depends on the case by case. So the question is, what is it? If I know a bit what it is, then I might decide, like for example, a polyp. I might tell them that they have something and they should see their family doctor, and I'll write them a note to their family doctor. On point of your ultrasound, I've seen maybe a small polyp. A patient will follow up with you for a repeat ultrasound. And so I have essentially a proven documentation that I keep in the chart, one copy, give the other to the patient so he can follow up with this. And then, so there's continuity of care in that sense. If there's really something like, I'm looking at, I don't know, in the pelvis and I see this bicystic weirdness, I'll for sure do an ultrasound in the ED, because that's the easiest thing for me to follow up on and follow on the results without delaying care. So it depends at the bottom. So essentially depends if the patient can have follow-up with a GP, or is the patient has a follow-up with a consultant. So let's say, for example, the patient will see surgery because he has a referral. Well, then here's your like, you can have the formal ultrasound and see them as well. They'll follow up on the results. So I have somebody who will follow up on the results of the imaging study. It's a bit the same thing as asking a bit of HCG in 48 hours when the patients will have follow-up with the early pregnancy assessment clinic. Like, I ordered the test, but I know they have follow-up in a few days. I'll be scheduled to follow up those results.
Okay.
So that's one option as well.
Okay, I was wondering because I know sometimes, and I'm not qualified to comment on it, but like inside the bladder, you see a little blimp floating inside. So I'm like, what do I do with that? I'm not qualified. Do I just do nothing? Do I was like?
Some people might close their eyes. It's just like,
oh no.
Okay, I don't see these notes, but it depends. Any clear follow-up. I'll ask for formal, and most of the time, the bladder will mean either there's like it's a clot because they're hemorrhaging, but even if they have like passing clots, you do a formal ultrasound, the radiologist will say on the formal ultrasound, most likely clots cannot rule out underlying mass. It's always what they're right, even if the patient's having active hematuria. So they'll need anyways a follow-up with urology.
Okay.
No matter what. So, but I'll ask for the formal at that point.
Just to back you up. Okay, good. Thank you. Any other questions in the group? Or do we leave Dr. Brisebois to go back to his shift? All right. So thank you very much.
My pleasure. Take care.
And, good shift.
Thanks. Bye-bye.
All right. So our next presentation is going to be another of our residents. So Harmeen is going to be presenting her grand round this year about implicit biases and common ED practices. So Harmeen, I don't know where you are. All right, I see you.
Give me just a second. I'm just setting everything up. Let me see if I can just share. Oh.
So I love how today's rounds, without necessarily knowing it, are really related to what the many subjects we talked about during our retreat.
Exactly.
About research, and now we have those biases that we talked about.
Perfect timing. Okay, let me just know if you guys can see everything.
All right, that's good.
That's fine?
Yeah, I'll make the presentation.
All right, so hi everyone, my name is Arlene, I'm one of the PGR3s. So today I'm going to talk about implicit biases and common ED practices. I'm going to touch on a few subjects and hopefully spark a discussion for you and your colleagues. So the objective of the presentation is pretty simple. You guys are going to be able to list different implicit biases that we have in emergency medicine. We're going to be able to talk about some research studies and literature that will help us debunk some of those biases and some of those ideas that we use on a daily basis. And then we're going to be able to identify ways to counter some of those practices on a day-to-day basis. And hopefully we're going to be able to remember a few things. I see something in the chat. No, okay, that's fine. So I do not have any conflict of interest to declare. So whatever I say, you can take and bring back home. I'm kidding. Perfect. So the plan of the presentation, I'm gonna just go right ahead. So what is implicit bias? Essentially, implicit bias is a bias that involves an association outside of your conscious awareness, and that will lead you to misleading, often negative evaluation of a person or a patient. So this is usually on the basis of characteristics such as race, ethnicity, sexual orientation, or gender. And the research has shown that as physicians, we do have the same essentially rate of implicit bias as the general population. So we're not exceptional, essentially. That's what we have to do. So I want to make a clear point about what the difference is between explicit versus implicit bias. So implicit bias, as we said, is the gut reaction. It's the millisecond. It's you walking down the street and looking at the old lady that's moving with her stroller and not feeling threatened whatsoever, but for some reason that you can't really express, you do feel a little bit threatened by this young gentleman that is walking with a hoodie towards you in the middle of that same street. It is the feeling, the behavior, the judgment, the thing that you are unaware of, but that will still affect the way that you are going to interact with individuals. And that can happen in your daily life, but it can also happen in the emergency departments. Explicit biases are some things that we are all kind of aware that are bad. We know how to react to that, and we know that we should not promote that. So it's the thoughts, it's the hate speech, the discrimination, those words that are said that are pretty intense and kind of like right away spark it. Oh, that's really bad. I don't want to be a person that says things like that. But we're more talking today about implicit biases, and that's why I want to make a clear difference between the two. The themes that are associated with implicit biases can be one of many. You can talk about race, sexual orientation, gender identity, the socioeconomical status of your patients, professional background that they have. So we don't have a tendency necessarily to treat people that are from the healthcare field as other individuals. So that's also why sometimes you will see on your charts that it is written travaille pour le MUHC, or works at the MGH, or is a physician, or is a resident. These little information, these little cues that we give ourselves do have an impact on how we treat patients, and that's things that we have to kind of keep in the back of our mind. There's also the language barrier that I like to touch on, because the concept of language barrier will make it that we look at certain patients and we can get frustrated at the idea that we are not able to communicate with them as well, and we kind of fall into this acceptance of well, I'm not able to communicate very well, but I get a pretty decent idea of what's going on, so it's fine. I'm not necessarily going to push further. So we have to be careful with all of these things. There's a warning that I'd like to give, and that's very important. I like to talk about this in the very beginning of my presentation, is the feedback about biases. It can trigger emotions that will reduce the effectiveness of the feedback. So whenever somebody comes to you with a, maybe this practice is not appropriate, our immediate response can often be one of, well, I am not this, or I am not that, or I'm not a bad person. But we're not here talking about being a bad or a good person. We're really just talking about the things that have been embedded in the way that we practice medicine that may influence the way that we help our patients. And being aware of them is the first step to improving ourselves. And that doesn't speak to whether or not you're a good human or a good doctor. It's really just a question of being able to recognize the ways the system has influenced us as individuals. So yeah, that's pretty much what this says. I'm not gonna go into much more details than that. So implicit biases and how they erode the relationship between us and our patients. You might recognize the drawings of osmosis, which is an amazing resource that I go back to all the time. So what can happen? If a physician is unaware of their prejudices, they can maybe not recognize how their behavior and language and actions will marginalize or put a certain label on the patient that they have in front of them, which in return makes it that that patient feels like they're not receiving the best care. And in reality, objectively, it is also possible that that patient does not receive the best care in that context. For that patient, there's a concept of respect, confidence, trust in the provider that will be influenced by that relationship, unfortunately. The IAT scores, we're going to talk about the implicit assessment test that has been developed by Harvard. We're going to talk about it a little bit more further, but when those scores are high, there is also a question of distrust that comes with those providers that have a high score because of the way that they've been interacting historically with those patients. And so the patients will develop a lack of confidence in the treatment plans, and they'll have a hard time remembering that interaction with the physician in a positive light. That will make them likely unhappy with the care that they receive, and maybe there will be a lack of trust, a dissatisfaction. So all of these things will have a very negative impact on the relationship between the two. Few results that are interesting that I'd like to point out. A study in 2015 did report that most healthcare providers appear to have implicit bias in terms of like the positive attitudes towards white people and negative attitudes towards people of color. And then these implicit attitudes were more often significantly related to patient-provider interactions and then health outcome than the treatment processes per se, but this is still important to know. There's another study in 2019 that's a bit different. It's not necessarily related to the patient interaction, but rather to the perception that we have as residents. And they studied emergency medicine residents compared to OBGYN residents in the US. And they proved that there was an implicit bias that was favoring men in leadership positions rather than women in leadership positions. And that bias was exacerbated in the male population and in the EM population. Now that study also stipulated that maybe that the bias was exacerbated in EM because EM is a mostly male-led profession in the US rather than OBGYN, where, for example, male residents in OBGYN will have been used to seeing women in leadership positions, which might have influenced their response in that regard. Sorry, I just saw message. Sorry. One thing to realize is that we all have implicit biases, even those of us who are people of color, and that is normal, but it is important, especially as professionals, to analyze them. Absolutely agree. So I did receive that as a direct message, but I want to share it with the group. The implicit biases that we are talking about is valid for everybody, right? So people of color, or people that are women, or people that are from specific sexual orientation groups and whatnot. Everybody is subject to implicit biases. I am, you are, everybody is. And that is why it is important for us to look at this as a group and as individuals, and to not point fingers. And I'm going to talk about this a little bit later, but the idea of all of this is not to point fingers at one specific person. It's rather for us to be able to like analyze ourselves and improve our practices for the betterment of our medicine and for the betterment of the treatment for our patients. So heuristics is the word that I just learned. What does that mean? So essentially, there are a few studies that report that, and that is very, very important for us in the emergency department. Stressors associated with the emergency department can increase our need or our desire to rely on cognitive heuristics. Heuristics being shortcuts, being the way that we make clinical decisions based on things that we already know. And it does put us at risk of doing, for example, premature diagnostic closure. So if the ED is very, very busy, and they analyzed that in one of the researches that they did with residents in 2016, they assessed the implicit bias of emergency residents in a pediatric emerge, and they looked at cognitive stressors, like for example, the overcrowding of the emerge, and they assessed that with a specific tool that was assessing the wait times in the waiting room associated with the number of patients that were on stretchers, number of patients that had to be seen within X number of hours, et cetera, and the patient load, so how many patients each resident had to see, and they considered a high load every resident that had to see more than 10 patients. Whenever those cognitive stressors were present, their analysis showed that there was an increase in implicit bias following that. So it is interesting to kind of keep in mind that it is something that we do often in emergency medicine. We do use shortcuts, we do use heuristics in order to do pattern recognition, but it can also have a deleterious impact on the way that our biases will express themselves in reality. So then the question remains, like, heuristics, is it all bad? Like, can it also be a little bit good? Because we are emergency physicians, and we do have to make a lot of split-second decisions, or rather rapid decisions that will have high impacts. And I kind of like the quote by Alvan Festine, which was, every observant clinician has discovered that certain shortcuts or other maneuvers, either of intellect or of action, can increase the efficiency of his work in clinical practice. And we use that so much in eMERGE, and it is so important, and it has a lot of positive impacts. Right, so it does allow us to analyze high impact cues, and so it allows us also to recognize some patterns. It allows us to separate signal from noise, or asking the right questions. The image of the baseball player is one of a player that is able to focus on that ball at all times and can ignore the crowd, can ignore the noises, can ignore the opponents to be able to catch that ball. And in eMERGE, if we want to catch those diagnoses, if we want to make those right treatment plans, we need to also be able to focus and ignore the noise. And by using some of those shortcuts, we're also able to do that. So where is it that we actually drop the ball? Like, how do we, I see Antoine very much enjoying my sports analogies, so I'm very happy to not be alone in that. So where do we drop the ball? So there are a few studies that came out, 2020, the indigenous population that has experienced discrimination from healthcare providers related to implicit biases in Canada was counted to 28.5%. And that fact then definitely dissuade them from seeking future healthcare and contribute to their detrimental health outcomes, either because they choose not to consult early enough, and or because they are subject to discrimination at the moment that they do consult. So these are things that we have to keep in mind. False assumptions can also increase when certain populations are overrepresented or underrepresented in the ED. There was a small research that was done in Australia that was kind of comparing how I think the indigenous population in Australia was 3%, but then in a specific emergency department, they represented up to 7%, so almost more than double what their number in the population. And so it can also give physicians the false sense of, well, I know what the issues of these populations are because I see them so often in the eMERGE, but we also have to be very careful with that. Subsequent effects on patient health outcomes. There was a study by Quigley in 2020. They were saying that there are implicit racial biases in ED physicians, but we do need to have more studies on how these biases will have an impact more specifically on the patient outcomes. And it is very difficult because there are so many factors that are involved in it, but we still have to keep in mind that it is undeniable that interpersonal and institutional racism does contribute to the persistent healthcare disparities among racial minorities, amongst other things, because it's not only about racial minorities, it can also be about sexual minorities as well, or gender minorities. And so that is something that we have observed a little bit more in COVID, and it has been expressed a little bit more in the last 2 to 3 years. And it is a good thing that we're talking about it now, because hopefully things are going to change in the upcoming years. There is evidence. There's not a lot of it because the research is starting and people are getting more and more interested, but things are going to come up in the upcoming years. But there is already evidence that, for example, some ethnic groups will have disparities in the way that they are triaged in the emergency department, or the way that they are going to have radiographic assessment prescribed to them, or the way or the speed at which they're going to go to coronary angiography, or the wait time for their elective surgeries, and the analgesia recommendations that are going to be provided to them. So these are all things that we have to kind of keep. I put in the references, so you guys can definitely ask me for them if you want at the end to look at those studies. So these are all little interesting things that I figured I would share. Controversy maybe, and I talk about this because we can't only just state things in one way and not kind of look at the other. So the IAT has been used a lot and extensively. I think you've all kind of like heard of it. The IAT is this test that's been developed by Harvard that is supposed to measure implicit bias. So they put you in front of a computer and they show you an image of a person, and then you can have, I think you have the IAT for the race, for the gender, for the age, and a lot of different groups, and they're basically assessing the speed at which you will associate certain groups with certain characteristics. So they will, for example, put a picture of a young person and a picture of an old person, and they will ask you to associate that with words like, for example, lazy, old, dysfunctional, strong, et cetera. So you have to associate, and they want you to do it quick so that they can measure these implicit biases rather than these explicit biases. So a lot of studies have been using this tool as a objective measurement of implicit bias, because the subjective measurement of implicit bias would be to ask people, hey, do you think you have implicit biases? Do you think you favor one group over the other? And most people, and I included, will oftentimes say, no, not at all. I definitely don't do that, or at least I really hope I don't. But then what happens in reality is oftentimes different from what you actually think you do. And that is valid for all. And so we do have a tendency to favor people that look like us. So I would have a tendency to favor women. I would have a tendency to, and et cetera, et cetera. So the IAT has been criticized extensively in the last couple of years because it was developed in the late 90s, if I'm not mistaken, and it was used very, very often. But at some point, people started to question whether or not this tool was actually good to evaluate the implicit biases, keeping in mind that the validity between the validity between one response to the other is not as strong as we thought it was. And there is no significant difference between the IAT's results and whatever results we get when we compare it to people reporting for themselves whether or not they have implicit biases. But all of these studies that are kind of questioning the IAT are also somewhat flawed. So this subject is such how could I say this? It is such a refined subject that it is sometimes difficult to find the right or wrong. And I have a tendency to believe that it's a good tool that exists that allows us to spark the conversation. It is not perfect. It is associated with issues, but if we know how to use it just to spark conversations, then we can definitely make change applicable. And sometimes it's not just about having a percentage that is reported by an objective tool, but rather sparking a conversation, because qualitative data is also relevant just as much as quantitative data can be. So there was a systematic review by Dehaan in 2017. That was a big review that essentially was debunking completely the AAT and stating that it was completely inaccurate and that it does not impact the clinical decision-making, and that even though people can have certain scores on the IAT, it wouldn't change anything in the way that they treat patients. But there was an interesting response letter by Dr. Samuels in 2017 that was warning readers by saying that those systematic review studies that were used for that systematic review were using artificial clinical vignettes. So they were asking people to complete the IAT, then providing them with a artificial clinical vignette and kind of assessing the association between their IAT score and how they would treat a patient from an artificial clinical vignette afterwards. But what she's saying in the letter is that there can be a very significant discrepancy between what a person says they would do and what they would actually do in practice. So if we do want to assess that properly, we would have to essentially follow physicians like in the emergency department. And it's possible that those studies that were included in the systematic review was overestimating the true performance of people that were also subject, like where we as physicians also want to have social desirability. So we do have a bias associated with that. We don't want to be bad people. We don't want to be bad physicians. So the way we respond to artificial clinical vignettes is not necessarily fully representative of what we would have done in real life. So then I'm kind of touching base on the fact that the danger arises when the implicit bias combined with evidence-based medicine, that we also have to be careful sometimes, because evidence-based medicine is also influenced by sometimes culturally blind processes and biases in a way. So that can sometimes result in a higher risk of implicit discrimination, poor treatment, or misdiagnosis of our patients. So we have to be careful. And so I'm touching on a few little subjects that I found interesting, and I'm using quotes that I have heard or that people I know have heard in the emergency department related to certain subjects. And I'm kind of like hoping that we can spark the conversation and kind of talk about these things and see what we can do better. And maybe you guys are going to have suggestions as well to add on to what I have to say. So anemia. Oh, well, it's probably her baseline anyways. Happens relatively often that I've heard that especially when we do a CBC, well, we're kind of stuck with a hemoglobin, even if, for example, the only thing I wanted to look at was the platelets. And so it happens. How often has it happened to you guys that you are this close to discharging a patient, this close, and last second, you see that hemoglobin that's like 99, 96, so kind of low, not horribly low, not to the point that you want to transfuse them, but at the same time, you don't have a baseline because she hasn't been in the system anyways. So you go to your staff and your staff says, well, it's probably her baseline, it's okay, or tell her to follow up with her family doctor or whatnot. Why I'm talking about that is that because anemia, the prevalence of anemia has been reported higher, definitely in specific like non-Hispanic white racial groups and Black racial groups and other people of color. And the question that I want to raise is, would it be possible that these differences can be explained by social determinants of health? So that's one of the things that we have to keep in mind. And of course, we also have to keep in mind that it's not because the prevalence is higher that every BIPOC individual or woman that is going to present with a low hemoglobin, that's going to be their baseline. And so I want to raise the question to go that extra mile to make a difference, to check the DSQ if they have not been in your hospital before, just to make sure that that 96 is not actually a 96 that's coming from a 132 in the last couple of months. Question their menstruation, ask for that extra iron profile, or make sure that they do have proper follow-up with their family doctor so that that checkup can be done. But if the patient doesn't have a family doctor, then maybe we should question ourselves as to, do we have a responsibility to just assess that to be able to make sure that the patient is properly treated. One of the main examples that I have of that is a patient that I had. She was a young 19-year-old that presented with a story of, I've been tired for months now, and she had been consulting a few times, and she was never found to have anything specific. And when she did come to the emergency department, she was a impressive walking hemoglobin of 53. That lady, unfortunately, had been bleeding for months and had been tired for months, but is it possible that her hemoglobin, even if it had been assessed in the last couple of months, was always kind of like trending down, but not in a way that was acute enough to get anybody to react. And the last time she had been checked, maybe she wasn't like the 80s or the early 90s. And so maybe it was disregarded. So I don't know. I have no idea what what her story actually was, but I think it's interesting to see that, yeah, sometimes if we don't pay attention, chronicity can catch up on us essentially later down the road, especially in the emergency department. EGFR. Black people have more creatinine, no? I think so. I mean, that's why we don't have the same calculation, right? Because if you look at the labs, oftentimes you will see that you have a non-African American result and an African American result, and so technically you should look at your GFR in a different way if the patient is Black or not. But then again, what is Black? Like who's considered as a Black patient, and what does that mean in reality? And the race that was originally included in these calculations was because of clinical trials. Oh, sorry, let me just, I just noticed that my computer is about to die, and we don't want that. Give me just a quick second. I'll just, okay, we're good. So essentially it was because clinical trials had demonstrated that people who self-identify as Black or African American can have on average higher levels of creatinine in the blood. And so we were thinking that, oh, muscle mass, diet, kidneys eliminate creatinine differently, and so this is why. But at the end of the day, we have to remember that race is also not a biological concept specifically, but rather a social construct. And so we have to be very, very careful, because what do you do with a person that is half Black or half white? And what do you do with people that are from Latin America, for example? Where do they fall in that calculation? So in 2020, the National Kidney Foundation in the States decided to create a task force to kind of look back at this and trying to create a new race-free calculation for estimating the EGFR, and kind of like steer away from these tendencies that we have to classify people based on things that can be oftentimes a little bit too arbitrary to be objective ways to practice medicine. And so eventually this new race-free calculation is going to arise, and eventually it's going to be tested, and it would be interesting to kind of like look at where this goes. Acute myocardial infarcts. But well, I mean, it's just, you know, women don't present with chest pain the same. It's just, it's not the same, you know. They don't really have chest pain. Like MIs in women, it's just, you know, sometimes you just don't know. It's just not clear. So under triage of MIs can occur in both sexes, especially in that study that was done by Kuhn in 2014. But it seemed that the under triage was even worse in women. And that led to prolonged treatment times for women with myocardial infarcts, which is a diagnosis that we know is important to recognize. There is that common belief that women are less likely to present with chest pain, or that they will present with symptoms that are a little bit unclear, but in reality, it seems that chest pain is still the very most common symptom for both women and men that present with an MI. The only thing is, it is true though that according to one specific study, that they can present with certain symptoms a little bit more often than men. So they can have a little bit more nausea, a little bit more back pain, dizziness, or palpitations that are associated with those chest pains. And I want to kind of make a note of the nausea and the dizziness that we often have a tendency to kind of like not ignore, but to kind of put on the back burner in emergency medicine. But we have to be careful with all of this, because sometimes if the chest pain comes with nausea, we do have a tendency to go, oh, well, maybe it's more a GI source rather than thinking heart disease. And same thing with the dizziness. Sometimes we'll associate that with more of the orthostatic standpoint, or associate that with the anxiety component. there was a study in 2018 that reported that 53% of women said that their provider did not think that their symptoms were actually related to heart conditions, whereas it only occurred to 37% of men. So we can wonder, why is that? You know, why is it that us as physicians, we don't necessarily believe women when they present with certain symptoms in terms of like, could this be heart disease or not? So one of the things that I kind of want to mention is don't assume, of course, use objective measures of risk stratification always, and always remember, like, especially in emerge, like we want to be careful not to go to the exclusion diagnoses as a first diagnosis, even if the story of your patient seems to be a little bit odd. Let's just keep in mind that, yeah, we do have to eliminate all of the bad stuff before we can jump to the conclusion that, maybe it was just anxiety for that person. Pain management. So interesting that too. Well, are they drug seekers? I don't know, maybe they are. And I've seen that in the chart once, and it was especially particular, and you will hear about it. And we had a beautiful presentation about it when we had the presentation on sickle cell not too long ago, where there was the notion that drug-seeking behavior is attributed to patients that present with sickle cell, for example, but this is not founded. And if we're not careful, and if we add those things to the charts, we can really have a deleterious impact on the treatment pathway for that patient. So I've seen in the chart already put like a query drug seeking as a, well, I'm not saying they're drug seekers because I can't know, right? But maybe, but I'm just presenting that as a possibility. But it doesn't make it any less dangerous if you put a query in front of it, because the next provider is going to look at your note and be influenced by that word. There's also the notion that Black people can handle pain better. So that's also a little bit odd. I don't know what it is in the melanin that makes individual a little bit more or less prone to feel pain, but it seems to have an influence on the way people are treated, because a study in 2015 did report that the appendicitis pain was already undertreated in pediatrics, but the racial disparities that were observed were even more impressive with respect to the analgesia administration. And so when they stratified by pain score and by ethnicity, et cetera, for moderate pain, those young patients were less likely to receive any analgesia if they were identifying as Black or non-white. And among those that had severe pain, they were also less likely to receive any opioids, more specifically than white patients. And so that's also a little bit concerning when you think that we're already not really good at treating pain in the emergency department. And if we're even worse with certain populations, maybe we need to be a little bit more careful with that. So steer clear of subjective judgment, steer clear of your own, well, they say that they're at an 8 on 10, but then they're able to do this or they're able to do that. So are they really have a tendency trying to go more towards believing patients, trying to steer clear of the, oh, well, they're probably drug seekers, especially if it's not founded on anything, unless you have a diagnosis of like a use disorder, then maybe be careful with those terms. Be proactive in the pain management for those diagnoses that we know are painful. Like it's known, it's well known. Pain is one of the criteria for appendicitis. Like you know it's going to be painful, and so if you know it's going to be painful, why be so guarded as to prescribe analgesia? And we're not necessarily talking opioids here. We're talking Tylenol. We're talking, So all of these, and then we can also use the concept of like preset orders, which exist in some emergency departments, where your preset orders for morphine or for Dilaudid or for Tylenol will be done in a way that you can just kind of like check it, and so you're not gonna tweak the way you prescribe your medication to every patient based on something that is completely subjective sometimes. I just saw another note that says that it's often, the drug seeking or frequent user of the system is often added to the triage sheets, which may already create a bias even before we see the patients. And I definitely agree with that comment. This is great. And that's also something that we have to keep in mind. Beta ACG, listen, she says she's not pregnant or she's not having sex, and we can't really believe her. So just test her. just test her. That is something I've heard a lot. And it is well known that in emergency medicine, we kind of have to or really, really want to test any woman of childbearing age with a beta HCG. And there's this urge to test them, all of them, regardless of what they report in terms of sexual abstinence or regardless of their sexual orientation. They tell you they have a partner and that partner is of the same sex, the risk of them being pregnant is quite low, unless I have missed something in my medical school. So it is interesting to kind of keep in mind that the way we decide to test those patients maybe is what needs to change. And I understand the underlying professional, medical, legal stress that's associated with that. If I have a patient that presents with pelvic pain and I did not rule out an ectopic pregnancy or a bleeding that is out of the blue in a patient and I don't rule out an ectopic pregnancy, I understand the medical, legal stress that's associated with that. I just have to remind you guys that we do have to ask for consent for those tests. And so if a patient refuses, technically we're not supposed to test them. If they refuse though, you can definitely write that in your note. Patient reports they are abstinent and blah, 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 and the patient refuses the beta HCG if you want to protect yourself. But then if you do want to test them anyways, maybe what I would suggest is just to change the way that we verbalize that. It's not a question of, well, all women lie or we can't believe them. It's just a question of, well, it is a simple test. It is a way for us to document the results and to have a written proof of that person is not a risk. And we try to avoid assumptions by doing that. And it's also to reassure us, and we have to be honest about this for ourselves. It is to reassure us as providers that, okay, I am not missing this. And I can go back home and go to sleep and feel better about myself because I did not miss an ectopic pregnancy in a patient that maybe 1 in a million would have lied to me. And so we do have to be careful as to how we justify this. And I say this because I've heard it so many times, like a keen medical student that will come and review their case and be like, well, the patient told me that they're not having sex, and the staff will look at them with poor child. If only you knew, they all lie, test them anyways. And that way of like looking at things can be a little bit deleterious for those patients. So I'm just going to read the notion of the comments I have, Dr. Chimiani. To be careful with this example, there are many reasons why patient may not be fully forthcoming about diagnoses and require a beta. Are you asking for consent for every CBC that you do when you're thinking about the possibility of underlying anemia to explain the patient's chest pain or shortness of breath? And Dr. Maya definitely agrees. And I agree as well with both of you. And I thank you for that comment. I do agree that we have to be very careful. And there are a lot of reasons for us to want to test that anyways, and to not necessarily go through with the whole consent people for testing every time the same way that we don't necessarily consent everybody to even though technically we should for HIV, for example. But I just want to spark the conversation, and I just want to have people think about it so that it's also something that we're careful with when we interact with our other residents or with other medical students, or in the way that we justify why we're doing the beta HCG. Because I think we have a very good reason to keep doing beta HCGs on all women of childbearing age. I just think we have to be careful as to how we justify it. And it's not so much so the whole like they all lie. It's maybe more of some of them might be uncomfortable, as Dr. Chimini said, but also it might also just be that we want to have that medical legal reassurance in a way. And other comment, it's not the urge to test that is wrong. It may be more related to how we explain why we are doing it. Exactly, agreed. And we should be careful with how we speak with trainees and be clear about our diagnostic reasoning rather than relying on flippant remarks that contain an element of implicit bias. And yes, 100% agreed. Thank you very much, Dr. Chimiani, for that. Yes. So how do we treat ourselves? Like, how can we do? Lots of undergraduate programs have been modifying their curriculum by adding, for example, Indigenous specific lectures or modules or shadowing experiences for their trainees to be more careful with those things. Maybe that would be an option for us too, and we've been talking about it, and there are ways. And for example, currently as residents, we all have to do the Indigenous awareness training that is mandatory, that was due for September 22nd, and I hope you all did. So these are things that are interesting. There's training in EDI that is a little bit more on the rise. Maybe go and explore what other EM programs across the country are doing in terms of EDI, and see how we can include that in our own trainings, and steer clear of shame-based arguments. Recognize, and that I really want to be clear about that, recognize the implicit nature of some of those biases. And so we're not talking about this to be like, hey, you monster, how could you have these biases? It's rather more for us to recognize how in the way we express ourselves or in the way we interact with some patients, sometimes some of these biases can be ingrained in things that we didn't even realize, and they can have an impact on how we interact with those patients. And we have to be more understanding of ourselves and of others so that we are all more inclined to grow. At the end of the day, if we shame each other, we're not going to go anywhere because we're going to fall on the defensive. But if we talk about it in an open way, then hopefully we can grow and improve all together. These are just a few examples of programs that have been trying to increase the awareness, because the idea is that if we want to get better, we have to be aware first. So we're having lectures, for example, and their example of intervention was for people to take the IET and then to have a conversation that was guided onto the results of these IETs. So they had to like discuss together about the experience of taking the test and the relationship between implicit bias and clinical practice, and identification of biases in your own practice and ways to mitigate the bias. Some of the things that we did, for example, what we did at the retreat is also a good example where we had a specific conversation about EDI. So that was a great idea and a great add-on to our retreat this year, I find. So these are all very interesting ways. So that's just exactly the same thing. So essentially mindfulness training. So notice the implicit biases so you don't let them go undetected. And so you can challenge the stereotypes that you have in and of yourself. And you take note, for example, of like the stereotypes, and you self-monitor and you self-regulate, and you're empathetic with yourself and with others in order to improve. There's a study in Ontario that also had residents go through like decision-making scenarios more specifically, and they were used to help participants like better comprehend the difficulties like of Indigenous communities and the difficulties that they face in the healthcare system. And once we had done that, the participant had an increase in empathy, an increase in knowledge, Indigenous culture, increase in motivation to engage in culturally competent practices. So all of these things were very, very positive. So these are things that we can think of. And to conclude, I kind of like this sentence, and I figured I'd add on that. Adopting cultural humility involves self-reflection of our own cultural biases. So that goes back to the comment that we had early in the presentation. We're all subject to this. So it's a good thing if we all talk about this so that we can all improve for the betterment of everybody. A lot of all and everybody, but like you get the point. So 2 other comments. I'm gonna just read them really quickly. I think the concerns you raised are all fully valid. Great presentation, by the way. Thank you very much. I do think that lack of first line in Quebec and lack of follow-up plus exhaustion of the staff and the ED do worsen things, agreed. Not saying that it should be used as an excuse, but it's still a thing, definitely. For example, it's way easier to assume that hemoglobin is baseline rather than trying to organize a follow-up that will be impossible to get for certain patients. So yeah, definitely agree with that comment. Very understandable. Another one, thank you for the talk regarding treating ourselves. Is there any research on whether diversity in med school residency program impacts implicit biases of trainees in these programs. I'm sure it's controversial though. Yeah, good one. I think so. I would have to look into it a little bit more. I know there's more research about that these days. Some of it is also more like letters that have been written. I know that there was a specific letter on that in one of the Canadian journals by one of the residents, I think in dermatology. So I do think that there are a few researchers that are starting, but the direct correlation between the lack of diversity in the curriculum and how it directly impacts the trainees' practices are a little bit less, I think it's not as obvious yet. It's discussed, it's something that is theorized, but I don't think it's been objectively studied thoroughly yet. And if it has, then feel free to come forth and let me know. But I myself would have to look more into this to be able to let you guys know.
All right. Very good presentation, Harmeen. I know those topics usually end up with a large discussion afterwards, and a lot of people like those and are a bit oriented that way. Unfortunately, because we're already a bit late on the schedule, I suggest that if people have comments or still want to have a discussion, you can do it in the comments.
Yeah.
And or just through emails. And I think I saw Dr. Roberts log in for his presentation.
Perfect. Thank you very much, guys. Have a nice day.
My presentation will be timely, so I'm willing to give you 2 minutes if you want to have 1 or 2 key questions to be answered.
Is there any other questions then about what Harmeen just talked about?
Maybe not.
Maybe not.
All right.
I know from the residents a lot came out during the during the retreat. So Dr. Robert, the floor is yours for your first talk this year about HI lecture that will be about the clinical workflow. Sorry.
All right. Just confirm you see my screen.
I do.
Perfect. Here we go. So thank you for allowing me to present today. So I thought just maybe before I start, there's a couple of words I want to make sure it's clear. So HI is health informatics. IHI is the Institute of Health Innovation. So it's a different concept. But so IHI is different from HI. Here we talk about HI, which is health informatics. So we have, I'll talk about it in a little bit, but we have a series of lecture last year and this year. We're going to cycle this every 2 years. So today's lecture is going to be on the concepts of process mapping and the value it brings in when you want to improve clinical workflow or improve a patient journey. Okay, so learning objectives as per the Royal College requirements. So I want you to understand what is process mapping and some of the basic terminology. So nothing more fancy, but enough to be able to draw one yourself that's suitable for most processes in the healthcare. We're gonna use one to describe some clinical workflows, some IT workflows, and patient journey. And during this lecture, and I want you to look at it to find ways to improve. So it's going to be a tool that once you've designed it or drew it out, be able to look and say, okay, what are things that we can improve? So we're going to kind of use a case example to get through that. And obviously, there's always a hidden agenda. I want you guys to be excited by healthcare informatics. I want you to be excited to consider doing an elective 1 to 2 months or a 6-month area of interest or even a fellowship. So let's see if I can get you excited. So it's a 2-year curriculum. Last year, we talked about general concepts of innovation, how design thinking and approach to be innovative can be used in healthcare, a little bit about data quality and data cleaning. We didn't do that last year. We will do it next year. And data analytics. That's year 1. This is year 2, process mapping, change management, and more about AI. Okay, so here's a case for you to think about. So imagine this is middle of the winter and you hear there's an ice storm, you hear, or you think, oh my God, this is going to be a busy shift. Let's say you're working in ambulatory care at the Montreal General. So you know there's going to be lots of patients coming in falls, fractures, and the ED is going to get crowded with those patients. Ortho is going to be busy. So that's the mindset I want you to have for this. And you're going to ask yourself a very specific question. How can you provide better healthcare? So just pause. When we say better healthcare, it means something, right? It means you're going to improve, you're going to make things better. You can talk about efficiency, decrease the length of stay for each of those patients. You can do quality, better pain control, better adherence to protocols. You can talk about safer care, meaning a right diagnosis at the right time, have decreased cognitive burden so you don't make mistakes. All that in the context of, healthcare innovation, healthcare improvement. You can kind of make them synonymous at this level of conversation. The healthcare practitioners use IT technology. So you can think about Oasis, PACS, Medjurge, all these softwares in the treatment, diagnosis, prevention, education, research, and outreach of your patient care. And when the patient comes in, it matters how they're seen, how they're heard, how their their needs are met. All of this is in terms of improving cost, quality, safety, efficiency outcomes. So that's the goal of healthcare innovation, and IT plays a big role in making improvements. It's not the only way, it's one of the way. Always when you're thinking about processes, about making things better, do consider it's beyond just the process. It's the people that are involved, it's technologies that are used, the process that are at play, it's the organizations you're in and the external environment. So for example, here for this case scenario where lots of patients come in and there's lots of fractures, to realize that the people you're involved with will be your PABs who may put in splints, your nurse is going to give medication, you're going to have orthopedic, the consultant team is going to be involved. There's going to be other patients that are crowding the waiting room. The technologies are the stuff that you already know. The processes, we have some collective orders that have been implemented for x-rays. There is pain control, collective orders that nursing can do. You have your own processes. When you see a patient, you evaluate them, you write a note, you may share this with your staff, or if you're the attending, you may act on your instincts of getting some x-rays, putting on, doing a reduction and cast. So these are different processes at play. You're in a healthcare organization, you're at the Montreal General, so there's going to be more patients coming in because it's a trauma center, external environment. You also know that you're in Quebec. So if you have an idea that's really good, it's going to make a difference, it's not that quick and easy to innovate to make it happen. In the US, it's a different environment. They actually put a lot of money in health IT over the last 20 years. They had a lot of funding, donation from somebody who passed away who wanted to say, here are millions of dollars to improve healthcare. And this is like 20, 30 years ago. So they've had funds for this kind of stuff. So obviously it's a bigger country. There's a lot of private care. So Quebec versus US, it's very different. So I think you have to keep in mind where you are, where you're working, the people, the processes, and the technology to kind of think of this. So let's go back to our case. So what are things that you know can make things better? And here I'm not going to teach you anything new. You know about this, but it's going to make you reflect. So on a busy day like that, with lots of cases, you want to improve team collaboration. You want to improve, how the nursing collective orders are actually implemented, or implement new ones, not on the day of, but thinking about these future days. You want to improve how you use your room and equipment. So just a bit more in detail, team collaboration, you want to make sure the team is ready to tackle this. That if anybody's kind of upset and frustrated that day, you kind of address and say, okay, guys, we have to work together. Today's a big day. It's very busy. We're going to have to take care of our patients and work as a unit. You may want to have more one-to-one conversations about making sure, your orders have been made aware to the right person at the right time so that they don't delay it accidentally. You want to get the patients to the x-rays right away, give them the pain control right away, turn over the rooms, get them clean so you can see the next patients. We talked about the collective orders. And in terms of room, we've done this already. We have a C-arm. We used to have a C-arm in, actually now it's back in room 7 at the Montreal General for reductions and stuff. Maybe using them better, having prepared kits for procedure sedation ready. I know right now sometimes it is difficult to get the team ready to do procedure sedation because the RTs and the nurses involved also take care of trauma patients. Sorry about that sneeze. All right. So now if you think about healthcare solutions, what do we know? Just to kind of put in context, right? Think about working at the trauma center 30 years ago, where everything's paper, the x-rays are by hand. In the last decade or two, the team who's been working in health informatics at the MHC, which includes Mark Bake and others at the Jewish, have made a lot of progress, have made things implemented. So the electronic order entry, being able to sit at a computer and enter the orders you want, or a group of orders, or click a set of orders at the same time, makes things easier. The electronic notification does happen to the right team members, and you can view the results electronically, start charting, voice dictation. So all these things are things or seen do exist. I'm just listing them here, but essentially it's things that have been implemented to make the workflow and processes better in individual processes. Yes, there's lots to improve and we can do better. So this is where I'm going to bring in the concept of process mapping. So we're going to map a couple of processes here. They're already done, so I really would need you to focus and follow me along with my cursor as I show you where I'm going through. I didn't find a better way than to put the images and kind of discuss together, but a couple of things you need to know. So a rectangle is essentially a process or an activity that happens. So for example, ordering medication is a process and activity. Evaluating a patient is an activity. So these are all in rectangle boxes. A decision leads to an outcome that's a yes or a no. It's a binary outcome. So you can say, is there fracture? So that's a decision point. So there is a fracture, you go left. There's no fracture, you go right. So it's kind of a binary outcome. And then the documents, if there's things to give, not as important, but there's a direction of flow. So the direction of flow tells you what's the next step, what's the next direction after the decision. So here we're going to look at something very simple and to show you how the implementation of the X-ray collective orders have made an impact. So to really understand that impact, you want to map out the current process. So this is a patient trajectory. So this is what happens to the patient. They come in, they go to pre-triage, they get a ticket, they go into the waiting room, they get triaged, they may get some pain medication. And this is not the single approach. There's variations to this, but I'm just drawing out a very common scenario. So from triage, they may or may not get pain medication. They go to registration, and then they wait for the MD to come and evaluate them. So this is before collective orders. So the MD sees them, decides the patient needs an X-ray. If they do, they'll go to the radiology suite here. So as you notice on the left side, it's not very clear, but it's waiting room. Then you have the triage and registration. Then you have the evaluation room, the procedure sedation or reduction room if there is needed, and then the radiology suite. These are locations where the patients will be going. And you've seen the different processes, right? And the arrows that show what happens after that process to the next. And as you go to the X-rays, wait for results, MD reevaluates, and there's a decision. Is there a fracture or no fracture? So if there's no fracture, they likely go home. If there is, then there's a question about, is there a reduction to do or no? So this is a simple process map where you have the different categories, and the category could be a location, could be a person's set of tasks, could be nursing tasks, physician tasks. So here are broken down by the patient, moving through different areas. These are all the horizontal layers, and through there, there's the different processes. So I think this is straightforward. I'll just pause and see if you guys have any questions about this diagram and what I've talked about so far, and then I'll continue.
Don't look like, I think it's fairly clear for now.
All right. So what happens if we implement collective orders? And we'll see the impact on this workflow for the patient trajectory. So patient goes to triage, and in blue, they get the pain medication. If they needed it, they go to X-ray, they go to registration, they get the X-ray done, and then they wait for the result. The MD sees them only at that point. So for the MD, by the time they see the patient, a lot has been done. And for the patient, you notice there's less waiting. They go from pre-triage waiting room to having an X-ray and then waiting for the results. So there's one less waiting time, and for the MD, there's one less evaluation, after which they'll decide if there's a fracture or not. So this is now after collective orders. This is before. I'm just going to go back and forth just to see, right? So you've taken out some of those processes. So you've decreased wait times. So this is one approach. If the collective order for X-rays is well implemented, you can improve the process for the patient. Now, again, what does this make better? It makes the length of stay better, but also improves the patient's experience. So they come in, they move through it. So when we talked about improving healthcare, all of these components are important, not only the outcomes and length of stay, but also the patient experience is part of it. So you can do an intervention that's only targeted to patient intervention, whereas here you're actually improving patient satisfaction, but also the clinical workflow. Okay, so now let's say we've done the X-ray for collective orders. And let's look at what happens from an MD perspective. So this is a bit more complicated. So I blocked these layers off for 3 scenarios. And again, now we have the MD. This is the clinical workflow from a physician's perspective. So you guys, so the MD has different things to do in their workstation. So the workstation to me is one specific working area. This is your desk, your computer, and you have all these things you can do. And the ED ambulatory area is the area behind you. In a, let's say at the Montreal General, it's whatever's around you. Is when you walk around the different computers where you see the consultant sitting, where you see the coordinator sitting. So that's the work area. I do understand that the workstations is within that area, but I did this just to illustrate a purpose and a point. When you're at your station, you can say that's a location where you spend a lot of time. The rest is in that walking area. And then you have the exam room or sedation room. So we have three, designated areas we're working through. So when you're sitting there, you might notice the measures that the patient is yellow. So that's your notification to say, hey, the x-ray is done. And assume in this case, it's only x-rays done. There's no blood. So you don't have to be confused. Is it x-ray or blood? So it's purely for x-ray patients. So it's yellow, the x-ray is back. Then you'll go into another software, Oasis, that you'll open PACS and you look at the images in PACS. So that's one set of processes that are being done when you're at the workstation. Then you may actually walk over to see, you'll evaluate is a fracture or no fracture. And then let's say there is no fracture, or if there's a fracture that does not require reduction, you'll either way ask the patient to be put in any room or just a regular exam room. And then this is me showing you that you're transitioning into the exam room. This is going in. So you see the patient, you may send them home right away because there's nothing to do. You'll come out and in your working area, like Clean Measures, Oasis, you'll write your note and you discharge the patient. If there was a reduction to do, as to no reduction to do after that fracture, you'll go into the room. You may apply a splint. You'll have to come out to create that ortho consult, print it out. You go back into the patient's room to give it to them. Now, granted, you may be proactive and say, look, this is a very simple fracture at this point, and say, okay, well, I don't need to go back a second time. I know exactly what I'm going to do. So you may be proactive and write your note and everything before you go in that room. But sometimes it's not clear. Sometimes you think there's a fracture or there's an area that you're not sure. You may want to consider maybe there's a fracture. You want to go evaluate the patient and then make up your mind and then write that consult for follow-up with ortho. So this is why I'm just drawing that second scenario that you may sometimes come back in the room once you made the final decision to do some work in Mental Oasis and then go back in the room. So potentially going back in the room twice and in between walking in and out of the room. Finally, let's say the patient did have a fracture that required a reduction. You may ask the coordinator to call for the RT, have the meds ready and everything. You'll order them in Medsurge, and then you'll cross into the patient room, evaluate them, put it on the splint, do the reduction. Then you'll come out, go order an X-ray in Oasis. You may view the results in PACS and then decide to write a note, make a plan, go back and see the patient, see, okay, they're awake, they're better, everything's all good, and they can leave. So again, potentially going back twice. Again, a single scenario, there's variations on this. You may go back and forth 5 times for different reasons. You may want to review with your staff, you may want to call ortho. So there's different scenarios, but I'm just illustrating very common processes. And then we're going to talk about how can you make this gigantic process better for each of these scenarios. So imagine your patient has a collective order. So the patient goes straight from the triage to their getting their pain medication, going for x-ray, and being wheeled into a specific room for you to evaluate them. In that room, imagine there is a screen already. So you know that if you walk into that room, you'll know what the fractures look like just by walking in the room. So you may not want to look at your computer anymore and go straight into that room where the patient is. Now imagine there is a workstation there, a workstation on wheel, or one like in the rooms we have in many of our departments, in both at MGH and RVH and ambulatory care. In some rooms, we have a computer there. So imagine there's either a computer on the wall for you, or you walk in with a workstation on wheel, and then you have a printer. Now, you might say that could be interesting. Let's say on a busy day, you just send the patients to that room where you might walk in and you have all the equipment that you need. So you may not need to have to go back and forth in different rooms. And so this is an idea that you might generate. You might hear about, you might see it at a different hospital and say, hey, I would like to implement this. If you started from this point only, you'd wonder, okay, what are the things we have to do? What is the impact we're going to have? You're going to wonder how many processes are being changed. So being able to map the process and seeing what changes kind of has this value. So here, we're going back and saying this yellow section is the same as before. You're going to look if there's a fracture or not. That doesn't change. And you're still going to ask the coordinator to kind of call a patient in a room or get the RT ready if there's a fracture that needs reduction. But now you moved all of the activities inside the room of the patient. So this is the exam room where you have access to PACS, Oasis, and Medsurge, where you would go in the room, make all your decisions and plans and get the patient out, print the papers and give it to them. So now you're talking about a room that's dedicated and maybe used regularly on regular days. And when there's days where there's a lot of fracture, you may decide to say, okay, we're going to dedicate this room to be the X-ray reevaluation room. You may dedicate a second room to be the X-ray reduction room where there may be a C-arm already. In both of the rooms, imagine you have a computer. Now imagine that the coordinator tells you, okay, patient's been triaged, they sent to X-ray. And then now the patient's in the room. So all you would have to do, your interventions really would start by seeing the patient being yellow, saying patients arrived. You might see that on the board, and you may just walk right away into the room. You could always check, you can still continue your workflow saying, okay, I'm going to check in OASIS and PACS and then decide if there's a fracture and then go see the patient. But you could also just go straight into the room and do all that work. So, and then these yellow represent the number of times you're going in a room. So it may decrease. So you decrease the number of times you're moving from room to room. Moving from room to room also means less interruptions, because if you go back to the working area, you may have somebody ask you a question that they wouldn't ask you if you weren't there. So, and you can start mapping out all of the improvements and benefits and potential downsides. One downside could be, well, what about infection control? If you have a computer in the room, who's going to clean it? How's it going to be done? Are you going to add more work to your PAB? So I'm not saying this is a final solution, but I'm walking you through the process of thinking about a solution, an interesting idea, and seeing that by process mapping, start sit there and say, okay, what are the potential challenges and benefits of this process versus the other? So that's the benefit. And this is something that all of you can do with your clinical background. So why is this pertinent to healthcare informatics is that when we do innovation projects or new improvements or new changes in any of our workflows, we either mentally or write it down. We do these process maps to understand what are the different steps and how do you get there. Unfortunately, the best people that are able to understand this are the clinicians. So, we've had interactions with a change in the laboratory system by the hospital IT team, and they really came to us to understand what is the steps that we do, what are the processes that we do, because they understood the generics and they've had a decent understanding, but really came down to it. We are the experts of the clinical workflow of our domain. So, this can apply for QI projects or research projects as well as for health informatics projects. Now I'm going to take you a little further. So imagine you're reading some journal club articles and you're seeing these come out. Okay, these are a lot of 2021, 2022, but they're talking about AI being able to detect fractures for, distal radius. They're talking about being able to have an X-ray detection for the femur fractures, or deep learning to come up with, other femur fractures, or more and more looking at fractures in the emergency room for trauma care. So then this is 2022, and I'll be honest with you, they're not ready. There's, poor quality of evidence that it's working well, or it doesn't work well based on the quality of X-ray, the density of the penetration, or people who have like cancer or osteopenia, they don't have good results. So this is not ready to be used prime time, but I would not be surprised in the next 5 to 10 years, this will be. And you might eventually say, hey, I remember the lecture by Dr. Arbo when they say AI is going to be able to detect fractures. Fast forward 5 to 10 years, or best case scenario, fast forward now. Let's say it's ready. So now you say, okay, well, we have this concept implemented now. Like we go in the room and the X-rays, everything is ready, but you still feel like I have to go in the room. I have to decide if it's a patient that has a fracture or not a fracture. What if you had someone else helping you? So you have, meet Adam. Adam is an AI bot that's been created that's able to tell you by looking at the X-rays that have been standardized for this process, the penetration, everything has been improved such that, these algorithms work pretty well. And Adam's able to tell you, hey, send to room 7, patient Mark Doe. He's got a tib fib fracture. He'll need an ortho consult. He'll need pain control because, he has nothing prescribed in the system. Or you may tell you, move this patient to recess because they'll need a traction splint placed, or will need a procedural sedation or a reduction. Or you may tell you things like, okay, let's add some pre-op bloods because this patient will need. So this is Adam who understands AI, who understands the orthopedic workflows, understands more than just detection of fracture, understands the algorithms that we have implemented. Imagine you have that. So imagine Adam can tell you, okay, Dr. Robert, go to room 7. This is the recommendations. Obviously, this is not a list of recommendations. I'm just giving you examples of what Adam could tell you. So you essentially just have to walk into that room and you already know what you're expecting, what you're supposed to do, and you're just going to execute. Maybe some of these orders already been, created by Adam for you, and just click yes. So how does that affect your workflow? How's that going to change? Because you need to make sure that it doesn't disturb the workflow, that it actually makes it better. And if it doesn't, you have to look at other things. So here's an example of an optimized workflow. So you are in the ambulatory area, you might be doing whatever you're doing, and notice that you're only involved as a physician down here. So Adam notifies that there's a fracture to the unit coordinator and tell them, bring the patient to a given room to do the following things. The coordinator acts on it and sends the patient. And again, you know, this whole idea of Adam being a good AI solution, the sensitivity, specificity, or in terms of AI, we talk about area under the curve, meaning how good is it to pick up most people in the right diagnosis, is not something that I'm telling you is ready today, but I'm saying, let's assume we've gotten that far and we want to implement it. You guys as clinicians who might be interested in taking AI projects will play that role of saying, okay, if we do that, let's do this process map. Let's be part of that process map to understand how that's going to affect you. So my suggestion is that algorithm runs, tells the coordinators to put the patient in the room, tells you what's going on, and you're going to walk into the room to either evaluate the patient and discharge them, evaluate the patient and do the reduction splint and then send them home. And you're going to do that all in the room. So you may actually start walking from room to room rather than going back to your workstation. Again, this is not the only way that you can get away from your workstation. This is an example that if we have this AI tool, this is the benefit that you're going to get, that you may not have to go to your workstation in your working area for patients that have fractures. So this is me giving you sort of a vision or an idea of what could happen. So there's a lot more that we can do. This is just a glimpse of how process mapping plays a role in innovation projects, how you guys are able to draw these process maps, be able to rely on your knowledge to kind of question, the impact of some of these interventions. But using this tool will be great if you want to be involved in health informatics projects. So what else? Well, you can work further, and this is not the talk for today, but you can be like, okay, well, what about the interactions with the clinician and that computer? Could it be purely voice? Could they just listen to Adam and respond to Adam with their voice without having to type, without having to put in the orders? Could the orders be pre-filled by Adam? Could the number, or maybe simply the number of clicks to create a certain prescription be decreased? So all of this is working on the IT or the clinician's computer interface. And this is a field of study of its own, but it's applied to healthcare and it's a part of health informatics, how you can make the interface between the human and the computer better, decreasing the number of clicks, making things more smooth, faster, less prone to errors. And that's, further drawing more diagrams about specific steps. That probably comes down to the IT specialists or those who do a lot of, process mapping or do a lot of software development, computer engineering, your contractors, or who you're going to pay to innovate the projects. They tend to do that more granularly. But if you can identify some of these steps, it makes the conversation better. So you bridge the gap between the clinicians and the developers by providing what you can as a process map, what you find are the challenges, and how you wish things to be better. So this is me trying to give you an idea of what is process map, the value of it, how you can use it to kind of understand clinical care journeys as well, and that can give you ideas of how you can improve or the impact of ideas that you want to implement. And always don't forget about our electives, area of interest, and fellowship that we have for you. And that's it. I'd be happy to open to any questions if there's any on my topics, or Antoine will guide the rest.
So I don't see nothing in the chat. So Kevy is now saying that it was really good. I was wondering how, so let's say most of us will maybe end up in a different institution than the RVH, where it's already implied, like it's already well implied. I was wondering how difficult it is to start all of that change, because by example, right now I'm in Trois-Rivières and everything is paper. They scan the papers, so that's their electronic database. But there's so I realize how fortunate we are and how the luxury we have back at the RVH. And I'm wondering, how do you present those things, or is it another presentation we'll have further down the road?
I mean, Antoine, it's like you planned this together. So our next lecture is change management. And it's exactly this concept of, if you want to achieve a project or you want to plan it out and implement it, once you know what you want to do, here's an example. Let's say you know what you want to replicate, an electronic order entry system or documentation in the ER. How do you kind of go about it, right? So that's the aspect of, you can take several approaches. One of them is what we talked about earlier, design thinking. So you start with like, what is the problem? What are the people feeling, and explain, and kind of understand them, make sure they are all on the same page. If everyone tells you, we love paper, all of us write really well by hand, and the paper stays in this area and it's perfect and we don't want to change, you're not going to be able to start that change cascade right away. So you really want to start identify the needs and kind of progress from there. But once you know that you want to implement it, you have to get buy-in from different people. You want to get the clinicians to be interested in that project and excited by it. So you might want to expose them, share your experience, share the benefits you've seen. You want the layers of administration to be willing to invest in that project, value it. And so you have to provide different people the benefits they can get with this. So essentially it's called getting buy-in from all the way from the top of the hospital, so the leadership there, down to the admin of the department and into the ER. You want people to be, one, excited, see value, and believe that you can lead it. So two things that are important is, first and foremost, we're all clinicians. Being a strong clinician will bring a certain amount of respect and acceptability of your ideas. Then you provide solutions based on your experience, bring in consultants if you don't have that experience, go do tours at different sites together. And, and it leads to focusing on what is change management. How do you get people to buy in, to implement and accept and be ready, trained to use it? So we'll brush up on some of these topics. Obviously, it's a whole chapter on its own, but we'll talk about it at our next lecture sometime in spring.
All right. And I guess also in the next lectures, you'll say how maybe, because I'm wondering if we change all of the sudden, especially in Emerge, is there more place for errors and therefore like danger for the patients and stuff?
Yeah, and it's all about the quality of implementation. Like even a clinical pathway, if you say now the medical students are able to order medication, right? Let's say there's a reason we do that and we do that. There's going to be medical students going to make mistakes. So you need to have sort of an approach to any change can lead good change and unanticipated change, and changes you can also mitigate by thinking about it and planning. So it's a great topic. I think you're developing keen interest in QI, change management, maybe in health informatics, but I think these are right questions, and it's not an easy answer. There's definitely a lot to do. Thinking about the people, the processes, the technology, all that stuff kind of comes in, factors into implement appropriately. And one of the biggest challenges in healthcare is the implementation. A lot of things fail because the implementation was not successful, where the implementation was flawed, didn't take into account certain things, they cut corners, didn't have the funding, not enough staff, not enough training. But change management is that topic that helps. Yeah.
All right, interesting. Can't wait then for the next ones.
Yeah, awesome.
All right. So this is all for our presentations. There is a 15